Somebody call the roll.
Good morning. This is roll call for the Joint Labor, Health, and Social Services Committee for Thursday, August 11th. Senator Furphy? Here. Senator Hutchings?
Here.
She's one.
Here.
Senator McEwen?
Here.
Senator Wasserberger?
Excused.
Representative Brown?
Excused.
Representative Connolly? Here. Representative Flitner?
Here.
Representative Hallinan?
Excused.
Representative LeBeau?
Excused.
Representative Ottman? Here. Representative Stivar?
Present.
Representative Worf?
Excused.
Co-Chairman Baldwin?
Here.
Co-Chairman Wilson?
Here.
We have a quorum.
Barely, right? How many? Nobody, don't everybody leave the room all at once, or we might be in trouble.
Madam Chair, is the, are we on YO guest or YO gov?
Guest, I would assume. Okay, the first topic we're going to consider is some follow-up from the June committee meeting, supplemental payment program for PRTFs. So
Do we not?
whoever we have for that, come on up. Committee, you did get the proposed statutory language should be lying at your desk. It has a little blue Post-it on it. That's the actual statutory language. We've never done that before. Wow, a crowd.
Madam Chairman, members of the committee, Stefan Johansson with the Wyoming Department of Health. I'll be very brief as a follow-up to our last meeting. The Department of Health presented basically an overview of supplemental payment programs, what we typically affectionately refer to as UPL programs or upper payment limit programs. Happy to answer any follow-up questions about how those work, essentially collecting assessments from various provider types and then having a formula to redistribute those funds after matching them with federal funds as a way to increase cost coverage. The idea here is to allow the Department of Health to pursue a supplemental payment program that includes psychiatric residential treatment facilities, of which Wyoming has 2 of those providers in the state, one here in Casper, WBI, and one in Torrington, St. Joseph's Children's Home. So again, very high level overview from our last meeting. What you'll hear from the Hospital Association and some of their colleagues are some potential options of what that could look like if current legislative language were amended to include psychiatric residential treatment facilities in these programs. And certainly if it's the committee's preference to consider and work and sponsor a bill potentially at the last meeting, we would certainly be available to work with LSO staff on what that language would look like. I'll close, Madam Chairman, by saying I think in general, the legislative vehicle could be relatively simple in terms of directing the Department of Health through a simple bill to pursue a supplemental payment program for psychiatric residential treatment facilities. Some of the legislative language you'll see in the Hospital Association materials today, as we talked about in our June meeting, does get relatively complicated in how the model could look. It all depends on CMS approval of what ultimately the Department of Health would be able to implement. So I think both approaches could be combined with, if it's the committee's and the legislature's preference to direct the Department of Health to pursue a program, that could be easily directed through a bill. And then if CMS were amenable to a specific model that you've heard discussed at your last meeting and potentially more here today, that legislative language could also kind of be on the back end of the direction to the Department of Health to pursue the program. So again, a little bit complicated on what exactly the model would look like, but the concept is pretty simple, that we have UPL programs in the state for various provider types that help the state increase cost coverage in Medicaid for those services. This would be allowing 2 providers who are really safety net providers for our adolescents with mental health needs to benefit from a similar type of program that does not require any general fund appropriation. I know that's a really 30,000 mile an hour overview, Madam Chairman. Happy to stand for any questions. But like I said, we'd be more than happy from the department's perspective to work with LSO between now and October on what the bill language, if it's the committee's preference, could look like.
Okay, questions for Mr. Johansson? I will say it may have been a mistake to put such a complex topic as the first one up at 8:30 after having come back of the summer off, because I do want to just clarify. So the attachment A that we have that does have amendment language, am I understanding? So if we decide that we want to go ahead with this, which was certainly the thought at the last meeting, I think I'm understanding that we could either, I mean, it seems to me that this attachment A just simply amends in the PRTF language into the existing statute. I mean, I did skim it rather quickly. So is that the simple version, and there is also a more complex version possible? Is that what you're telling me?
Madam Chairman, let me
coffee.
clarify. So what you have from the Hospital Association materials there is what potential amendment to current legislative language could look like if the model that's being discussed in those materials there would be approved by CMS. From the department's perspective, we can't guarantee that that particular model using the hospital UPL program we already have would be approved. Therefore, if the committee decided to sponsor a bill on this particular issue, the department would be certainly willing to work with LSO that would have a bill that potentially has two components. One, general authorization for the Department of Health to pursue a PRTF supplemental payment program. And again, that would give us authority and direction to work with CMS on what potential model could be approvable and implemented. The second component of the bill could be, for lack of a better term, some if-then language or a delayed effective date language with those types of amendments, that if CMS would approve of Wyoming using its current hospital UPL program to also have some redistributive properties or benefits to the two PRTFs in state, then great, we have the legislative language, in state statute to do that. But my first box to tick, Madam Chairman, would be general authorization to the department to pursue some sort of program in this area. That allows me, my department, the flexibility to work with CMS to see what would be possible. If what you see here in these materials from the Hospital Association, we begin to hear from CMS, no, there's certain components of this that won't work, we won't approve that. And again, I'm not saying that would happen, but it's possible with the complexities of these programs. It would be beneficial to not have to come back a year later to say, the department just needs some authorization to do something different. If we had the ability to start general, discuss the potentials with CMS, and then come back to this committee or come back in the next interim because something needs to be tweaked, then we would be able to do that. The general authorization to me is the first necessity if the committee and the legislature decides that this program should be authorized.
So given the time situation with our last meeting being in October and then session starting in January, is it your thought that a more basic authorization bill without this language would suffice to enable a program, if approved by CMS, to stand up in a timely way for the PRTFs without this language?
Madam Chairman, that's a great question. I do think that that's certainly a simpler approach. I think we would have, through a bill that gives us general authority to pursue a PRTF supplemental payment program, I think we would have the necessary authorization to begin that work, to work with CMS to amend state plan. Your question is a good one, that if we used the hospital UPL as a vehicle, would we have the ability to stand it up before the legislature meets again in 2024? I think in general, yes, I think that would be doable because of the implementation time it takes with CMS to make this happen, which is generally, I hate to be blunt, but it's 12 to 24 months to make these programs stand up. However, I do think it could be beneficial to again, if we could work with LSO to have the hospital amendment language ready to go, even if it's in the bill draft as a third section or a delayed effective date, that could certainly speed up the process. And I'm wavering, Madam Chairman, because I do think that the simpler the better in terms of giving the department the authority to implement something. I think could allow us to do it without complicated
So I'm
amendments
wondering
to
then,
current
and
statute.
LSO, just, your legal input on this might be, and I'm just trying to get this straight before we, you talk. If we were to just do a vote for a simple authorizing, pursuit bill, but say in that bill that should CMS approve an expansion to cover PRTF, that if it were necessary or advisable to go through the hospital program, that in that case, the hospital should be deemed to include PRTFs, just to kind of clarify that for your rulemaking. I mean, would that be useful? And LSO, is that something that would fly?
Madam Chairman, I think we would actually, well, that would be a little difficult just because we wouldn't necessarily have authorization to make the amendments to statute.
But I mean, if we wrote into this, if we had a bill, rather than use this entire attachment A, which it sounds like they're saying perhaps might be too specific for what CMS might approve, if we were to write as a more simple authorization to Department of Health to pursue a PRTF upper payment limit program with CMS, and if we were to say in that bill that could pass this January that in pursuit of this program, if necessary to amend it in this, then maybe we could ahead of time say that in that case, the hospital language could include PRTFs. I mean, that would be the statutory authorization to have that happen. I'm just don't know. I mean, but
I think that's possible. I'll have to check on it, but I think that's
sort of a psychiatric trigger bill.
right.
Madam Chairman, if I may add, as we've talked about with our hospital association and other partners, if this committee decided to pursue a bill in October, between now and let's say December, January, before we get into the thick of the legislative session, the department would work informally with CMS, as we do in a number of projects, to kind of explore what might be possible. We won't get formal answers, yes or no, legally speaking, but it has been helpful in other areas to work with them, work with our counterparts in the Denver office and the Baltimore office to see, so that we could inform the legislature prior to the session starting. Is any of this
Right,
going to
but
be doable?
but the only time that this committee has the ability to vote on language
Sure.
and a final language is October. So we need to have the text ready. And after October, you won't have legislative action until February of
Right.
24. So the more we can get into the box to make sure that you don't have trouble with the rulemaking process and have the AG's office say, well, you don't have authority to go beyond the plain word of the statute.
Madam Chairman, absolutely, and I would certainly defer to LSO on what might be possible there. I will say practically and operationally, from my perspective, the simpler the better, so that we don't get pigeonholed into a specific model that it could be early on in 2023 CMS says no on some component of it. So the simpler the better in this authorization, if it's the legislature's preference to do this.
Okay, Representative Connolly.
Thank you, Madam Chair. And I too agree that we really had a very compelling presentation last time, that this is a very good and necessary thing to do. So I am curious about, and again, we just got some of this language on attachment A. What, if anything, in an attachment A gives you a bit of heartburn that it is too expansive, that it would cause a problem? It looks to me like it's simply adding in the PRTFs after hospitals. It does have the fee raised from 0.5% to 1.5%. Is that heartburn for you?
Madam Chairman, Representative Connolly, my friends and partners to my left are probably have been thinking for months how paranoid this director must be. But I'll explain kind of why my approach is to be simpler and more general. It's not that this is overly expansive. There are components of this that I can't tell you today with certainty that would be approvable. For example, there's various requirements in these programs for how the redistribution formula works, what providers can and can't be included, and that's, I don't know if CMS will approve us using the hospital UPL program to benefit PRTFs for the following reason. One of our PRTFs in Wyoming is hospital-based. That's here in Casper. The other is not. Now, there's been discussion about affiliation agreements, those types of things that could totally make this possible. And again, not trying to sound overly paranoid here, but it's not a guaranteed certainty where authorization to pursue a different type of model that could be beneficial to Wyoming would be beneficial to my department to have, so that we don't have to go back to the drawing board a year from now if the legislature says we want a PRTF UPL program, but all you pass is attachment A to ride on the hospital UPL program and CMS says no, we have to come back for authorization. So it's really the ability to explore what might be possible with CMS. And if it were totally, different, a completely unique model that we would be considering implementing, obviously we would come to this committee in the interim with those updates on what might be a necessary additionally in statute. So it's not that this is overly expansive, Representative Connolly. It's that there's the specificity of it, of the vehicle that gets us there. There could be, and I think folks might think there's a lower chance of a denial than I do, but there could be a rejection of this at the federal level.
Okay. Any questions for Mr. Johansson? Okay, let's go on to you folks then. And I do just want to say for the committee, I before you start, I do understand that a gentleman that we have seen for several years on UPLs, the other Eric, passed away unanticipatedly during the summer, and so our condolences to his family and those of you who've been working with him. Okay, go ahead, Mr. Bowley.
Sue?
Oh,
Sue?
Senator Hutchings.
Yeah, I'm sorry, I had my hand up.
Sorry, I have to remember to look up there.
Okay, thank you, Madam Chair. This is to the director. Why do you need the legislature to authorize you to investigate what CMS may or may not authorize?
Mr.
Can you
Johansson.
go out on your own and pursue this without any type of legislation?
Madam Chairman, Senator Hutchings, that's a good question. We don't need authorization to have informal investigative discussions with CMS. What I was mentioning is if this committee decided to work or potentially sponsor a bill that would add additional components to our UPL or supplemental payment programs, that would be a good time to do it, is obviously this year. But Senator Hutchings, we can certainly have those discussions. In terms of the authorization, if we had informal discussions and it seemed like there was a model that could be implemented, could be approved, we would need legislative authorization to do that. I prefer that in any sort of growth of a program, even though this is not a state general fund program. Any sort of growth or addition to a program, I certainly prefer legislative involvement and authorization. Senator Hutchings, I'm not sure if that answered your question, but happy to elaborate if you need.
Okay, and from an appropriations point of view, I think because there would be pass-through dollars, that would probably require some.
Madam Chairman, yes, this essentially we have in all of our supplemental payment programs, hospitals, nursing homes, et cetera, we have budgetary authority legislatively to essentially increase our appropriation of federal funds.
Got it. Okay, Mr. Bowley, go ahead.
Madam Chairman, Chairman Baldwin, committee members, Eric Bowley, President of the Wyoming Hospital Association. And I think I'll let our team introduce ourselves first, and then I'll kick this off. But I do appreciate the thoughts on Eric Weatherford. It's been an interesting summer for us. But Eric and I partnered years ago, and we were able to bring a lot of benefit to the state. And he's our friend, our colleague, and he'll be missed. But we have a strong team here that will carry on his mission. I will tell you, Eric always talked about how much he enjoyed coming to Wyoming. He was always looking for excuses to try to pass new legislation just so he could come out here. And we actually had a mule deer hunt in the works. He was going to come out and spend time. So thank you for that.
Okay, the rest of you, go ahead.
Madam Chairman, members of the committee, thank you very much. I also appreciate those comments. It's been tough personally for us and our firm as well, but we're committed to making Eric proud today. So my name is Ellie Cochran. You saw me at the last committee hearing, and I'll also let my colleagues introduce themselves. They've been also working behind the scenes, and so they are not new to this project or this program or these programs in general.
Madam Chairman, committee members, Spencer Smith, and as Ellie said, we've been working behind the scenes, but we're fresh faces looking to continue to move this forward with y'all's support. Thank you.
Madam Chair and committee, my name is Joe Geraci. I had the honor and privilege to work with Eric for 22 years on different programs in different states. I haven't worked in the Wyoming programs before. That was Eric's, so I'm happy to meet you guys and help out.
Could you just spell your last name for me? I tried
Sure,
it.
it's G as in George, ERACI.
Okay, thank you. Go ahead.
So Madam Chairman, committee members, I just want to also express my gratitude for you making this happen today. My son's getting married on Saturday, so I got to run back to Cheyenne and then drive to Utah tomorrow. But I was committed to making sure that I was here for this, whether it was today or tomorrow. I would have just had to figure out how to get to Utah in time to be to the dinner. This is an important issue, and I think we did a great job last time of talking to you about what we're facing, what our PRTFs are facing. Last year, you all visited WBI, and I think it was an eye-opening experience for those of you that went through WBI and the mission that they serve. And I'm extremely proud to represent Wyoming Behavioral Institute. They fill a very important role here in our state. Just a couple of weeks ago, I was invited to speak at Rotary Club in Torrington, and Rhonda gave me an opportunity to go tour St. Joseph's, and I'd never been there. And I don't know how many of you have or have not been there. What an incredible facility. And I was moved as I went through that place, and as I listened to the stories. We have kids in our state that are in dire crisis. They need help, and we are not serving them. It is underfunded. Our PRTFs are facing a lot of the same challenges that other healthcare entities are. They're understaffed, but there are beds available. There's not enough staff. But those children, it's amazing what they do. And I would actually recommend that if we ever get a chance, we should get this committee over there to see St. Joe's. It's an amazing place. And so I'm committed to doing whatever I can to help these facilities. And I think this is a great solution. It's not the ultimate solution, but as we look at the legislation we're going to pass and the authorization to explore whatever options are available to us, our desire is to maximize the impact that we can bring in, to bring as much resources to those two facilities to serve the kids of our state. And when you see what the kids are facing and what the facilities are trying to provide, you'll understand why funding is so important. But I think we've got some great ideas. We've spent a lot of time working with Director Johansson and the Department of Health. And I think the team now can really explain what our strategy is, but we're just looking for authorization to move forward with something so we can get them the help that they need. I'll turn the time over to them.
Okay. Ms. Cochran.
Madam Chairman, members of the committee, thank you again for having us. And as you can tell, this is a complicated subject, and we've been workshopping it quite a bit. There are many ways to handle this and a lot of questions. And thankfully, we have an amazing director who is willing to work with us and talk with us, get on the phone with us and Zoom calls. And his concerns are not unfounded. It's funny, we talk about all of these different things, and I have opposite concerns a little bit when it comes to CMS and bringing these concerns. When we talk about attachment A, and you're so right, we have all these materials in front of you, and we can talk about, we can go through all the asks, but we don't really need to because Director Johansson gave you the 30,000-foot overview, and you've heard all of that already. What we need to talk about is the specific authorization that we are asking from you today. And it really is those amendments and what that's going to look like moving forward, right? And for me, I think my concern is when we start having these conversations and what this program really looks like, and we're hashing that out with CMS, that's where the rubber meets the road and the conversation starts. And my concern is that CMS looks at the legislation and says, where is your specific authorization to use these funds that, that you already have, this program that you already is successful in Wyoming, and use it for, on behalf of these 2 PRTFs. And that, but also, they could certainly say, well, actually, no. And Director Johansson could be right. We just don't know. And the truth is we're kind of playing a timing game, to be honest with you. And he's exactly right. It's a 12 to 24-month deal. And exactly what you just said, well, we got to figure it out by October, because if not, you know, this is when we're drafting the bills. And so that's the honest truth, is that we're trying to time this game and figure it all out and do these puzzle pieces, all while figuring out what CMS is going to say to us in order to maximize the funds that we can get for these kids. That's really what it comes down to, honestly. But fortunately, we're workshopping it, and we think that we've come up with good authorization and good language that we can give to you. So that's what we're asking for, really, is that authorization to move forward with the amendments to the bill. And I'll stop talking if there's any other questions that I can answer.
Questions for Ms. Cochran?
Or my colleagues, of course, they have.
Or do the 2 of you have other things to add?
Anything else you'd like to add?
Madam Chairman and the committee, I think I'll echo what Ellie said. And a lot of the amendments that we have, we feel that if we approach CMS with them, we already have the language. And like Director Johansson said, they're not going to give us a firm yes or no. But I do think the general approval that we're seeking today, we are prepared to go and speak with CMS already. This is not something that is going to take any additional time for us to come up with the amendments that we might suggest. We have option A, we have option B, and then we have experience in other states with types of programs that CMS has given approval for. So we feel well equipped to move forward and to address CMS and have a response by October with what the language that we feel CMS would be most comfortable with. So as they've mentioned, we're looking for the general authority because we are ready to implement that right away. Thank you.
Okay, anything? No, Mr. Jesse, all right. Representative Connolly.
Thank you, Madam Chair. Then I've got some questions about the specificity in attachment A, and just to understand it a bit better, if you're going to come back maybe with something different. So the increase from 0.5% to 1.5%, is that something that's been agreed upon by all member organizations? Is that a maximum limit? Where did you come up with, honestly, that increase?
Right, Madam Chairman and the
Mr.
committee
Smith.
members, I'll try to not get too into the numbers. Essentially, CMS allows for up to a 6% tax on Medicaid providers. Currently, we're at less than a 1% tax, I'm sorry, excuse me, not tax, an assessment on the hospitals. And so in order to generate enough funding so that our PRTFs reach their maximum reimbursement from CMS, we would need to increase that assessment, which all of the hospitals are in agreement with, and they're all willing to do that so that we can generate the non-federal funds in order to draw down the federal funds. So that increase in the percentage of assessment would be necessary to generate the funds to support the PRTFs.
Madam Chair, may I keep going? Okay, so curious, so you said it could go up to 6. I just hate having to need to come back, right? You put a number in a statute and you need to change it, you have to come back and change it. And so why the?
That's exactly, excuse me, Madam Chairman and representatives, that's exactly right. So the increase that we've done, if you look at it, that's if the assessment were to increase over 1.5%, we would need to come back and meet with y'all. So that's why we have increased that amount so that we do not need to come back and meet every single time for approval, which if y'all would like for us to come back, we're more than happy to, but this allows us to increase the assessment so that it's not necessary to come back each and every time.
Okay, good, thank you. Madam Chair, another one. So I am curious, and this might be for Director Johansson or DFS, but there's now some specificities that the PRTFs need to be licensed by DFS. And I don't remember last time if we talked about, we know that our PRTFs are for kids. Are there PRTFs that are for adults as well? I mean, like Evanston, and the answer is no. All right. So the licensing by DFS then makes sense to put in here.
Madam Chairman, Representative Connolly,
Director.
happy to go back between now and October and make sure that's as clean as possible. But in general, this is, the answer to your question is yes. Those facilities are licensed, but both enrolled as Medicaid providers and licensed by the Department of Family Services. So that makes sense. And they are specific providers for children that are not inclusive of adult facilities like the state hospital. Psychiatric residential treatment facilities, or PRTFs, as we call them. It's a very specific level of care defined in Medicaid for that type of reimbursement for adolescents.
So, Director Johansson and Mr. Boley, if I were to subsequently move for the committee to consider, for the committee to have LSO draft a bill, and I'm not moving it yet, committee, but that's why I'm sounding out the language with them, but pay attention, because then we could vote so we can, I mean, we've read, the PRTF type material for, a long time. So I'm not sure that we need to go over that, but if we were to have a simpler bill in Director Johansson's interest, that would, one, authorize the department to pursue upper payment limit program for PRTFs with CMS. And then second, just as sort of to Ms. Cochran's concern, to say it's the legislature's intention to authorize the department to appropriate or manage, or whatever the right word is, up to assessed revenue for the benefit of drawing down federal dollars to benefit PRTFs. I mean, you get what I'm trying to say in there. Would that be a simple bill that accomplishes what we want without unduly tying it up? And should I move that, Mr. Director,
Madam
in your
Chairman,
opinion?
Having not been elected to the legislature, I'll punt on your second question, but to your first question, I think that would be workable. And from my perspective, I think that authorization, as you described it, and I think the language between, from Department of Health suggestions to LSO could be massaged to make sure it's proper and specific authority. From my perspective, it gives us the necessary authorization. That text of a bill would presumably be in session law, that if approved, even if it's approved earlier than we think in calendar year 2023, statute could then, with that authorization, we have the authority, statute, if necessary, on the hospital UPL side, could then be amended in the subsequent session. I think that, Madam Chairman, I think that works.
I mean, my goal would be for, if CMS, if a miracle occurs and CMS moves faster, the faster we get help to these kids, the better. And if we can, kind of go out on a rulemaking limb and enable process to go on, that would be better. Okay, committee, in that case, if you'll get the gist, and LSO, if you'll just make sure that you understand, obviously the language will need to be tweaked a little bit, or you're going to work. But my motion would be for the committee to sponsor a bill that authorizes the Department of Health to pursue an upper payment limit program with CMS to benefit PRTFs in whatever form necessary. And second, just to cover the federal funds side, to give the department, say that it's the legislative intention for the department to have authorization to, I don't know what's the word I want to, well, I was just going to say not to appropriate, but to have the funds to manage revenue from that program to draw down federal funds to benefit the PRTFs. Is that work for you, okay, Ms. Anna? Okay, all right, committee, is that clear enough what we're asking, what I'm asking, would ask LSO to draft for October meeting? Representative Ottman.
Thank you, Madam Chairman. And you all, I mean, as we go through these acronyms, I think I just wrote down here, UPLs with PRTFs for CMS,
I know.
you know, so it's a little deep. But what I'm wondering, and I agree what you've just said, Madam Chairman, for a good way to go, but if you could, please just clarify for me, these assessments to the hospitals, then those funds would be used to receive matches, okay? And the federal dollars are under what category to get that match? And then also, how is that, I mean, just for clarification in my mind, how is that going to work? I mean, are those funds going to be kept and then distributed to these PRTFs? Can and are there going to be other ones other than the two that we have established? Are they all going to be tied to the hospital? If you could just give me that little story, I'd appreciate it. Thank you.
Sure, absolutely. I'm sorry.
Whoever, which of you juggled the plate? Ms. Director Johansson.
Madam Chairman, Representative Ottman, it's another good question. As an aside, I think if I stay in this job long enough, I will only speak in acronyms. It'll be my only language. And so apologies for the overuse of those. To answer your question, yes, these dollars work when the assessed basically fees to the provider types that are included gets collected by the department basically into a pool. We match those with federal dollars, and how it works is basically our general, what we call FMAP, or Federal Medicaid Assistance Percentage. And that's our federal match. So we use non-general fund dollars, so assessed fees on providers, match those with federal funds, and then based on a formula that has to be approved by CMS, redistribute those to the eligible providers. That's really the way it works, and happy to expand on that if you need.
Representative Ottman.
Follow-up, thank you, Madam Chairman and Director. So with that, then it will be primarily the two programs. And also, does CMS just have this funding available for these particular, for this task? Or is this a new program or?
Madam
Thank you.
Chairman, Representative Ottman, so two answers to your question. Yes, right now we have two providers that would meet this category in state. Presumably, if another provider were to enter and enroll in Wyoming Medicaid and be a psychiatric residential treatment facility for youth, and this was authorized and on the books, they would benefit as well. But right now, we only have two providers in the state. So hopefully that answers that question. In terms of how the federal funding works, this is a program that's available to all states, to all Medicaid programs for a variety of provider types. So many states have hospital UPL programs like we do, nursing home UPL programs, private physicians, et cetera. States have a bit of flexibility to elect which providers they do these types of programs on within limits. But it's not a grant that's been authorized temporarily. These are, unless the feds were to change the law or the rules, these programs are available, and it's essentially a way to that the federal government participates in matching dollars at providers and increasing cost coverage.
In 2021, this committee sponsored the emergency medical, the ambulance upper payment limit program came through this committee and passed the legislature. And so this is about our fourth or fifth program, maybe, or maybe there's more. Okay, anyway, Representative Stivar.
Thank you, Madam Chairman. The question I got is, will this help the step-down facilities like crisis centers and stuff?
Mr. Johansson.
Madam Chairman, Representative Stivar, not directly. This financial allocation, if it were approved, would only benefit the two providers that we've been discussing. I think there's probably some secondary or tertiary benefits there for the mental health system in general, that if our two providers that are really a much higher level of care for psychiatric treatment for youth, if they were more financially sustainable, could take more of our children, could provide additional services or additional bed days, that reduces stress on other parts of the mental health system, but more of a secondary benefit there.
Follow up, Madam Chairman. But some of these youth that come out of these facilities need to go to a step down, like a crisis center and stuff. That's why I'm asking that question. Could this, in a roundabout way, help these guys out?
Madam Chairman, Representative Stivar, again, it's a good question, and I think there are indirect benefits there. To use your language in a roundabout way, I want to be clear, it's not a direct financial benefit to them, but having providers at a higher level of care that have increased cost coverage and therefore hopefully would be able to partner with the state on essentially admitting and caring for more of our at-risk and crisis children will certainly benefit upstream and downstream our mental health system for the kids.
I would think that the less general fund money we're spending, and I'm not using the word bailing out in a bad way, but the less pressure there is on the general fund to help the PRTFs, in a way that frees up other capability to help other providers, I would think. Representative Hallinan.
Thank you, Madam Chairman. Mr. Bowling, the assessment is going to be applied, is that going to be applied to every hospital in the state? And are only the PRTFs going to be benefited from that assessment? Thank you, Madam Chairman.
Mr. Bowling.
Madam Chairman, Representative Hallinan, it's a great question. And the answer is no, not all the hospitals will be assessed. Depending on the plan that's approved, the state plan amendment that's approved by CMS, potentially the private hospitals could all be assessed. And they are all aware of that and are willing to participate to help get the financial help to the PRTFs that's necessary. But it wouldn't be all the hospitals, it'd be the private hospitals in the state. Potentially, it could also just be the two PRTFs, but what we're trying to do is maximize the amount of money that we can bring in to help these. And the juice has got to be worth the squeeze, so we're trying to maximize that. And that's why we wanted to attach it to the private hospital UPL, because it would allow us to bring in additional funding.
I think the discussion that we had at the last meeting was that the benefit to the other hospital, the regular hospitals, is that if the PRTF system is strengthened, they're less likely to have adolescent patients basically boarding over in the ER in the acute care hospital waiting for a room. I mean, I think it's obvious. It seems to me that all the hospitals see a benefit to them, or they wouldn't be having Mr. Bowley here at the table arguing for it.
Madam Chair, it's a great point. And so this would not eliminate the existing private hospital UPL. This is an enhancement to that. So there's still benefit through the other UPLs to the private hospitals, but to all hospitals are a huge benefit, because we're seeing our ERs used as boarding places for all these patients that need mental health treatment, and it's not available to them. And so there are all kinds of downstream benefits to all the hospitals and the healthcare in general in the state.
Did I hear a question on this side? Senator Hutchings.
Thank you, Madam Chair. I have probably three of the ugliest questions to ask, and anybody can jump in and answer this. These programs, actually, they bother me. The first question would be, where is the federal government getting this money for you to draw down? That's question number one. Number two, what will be the strings attached to our state, to the hospitals, the new facilities, whatever, once the federal government gives you money? And number three, is there any way the state can do this kind of program on its own? It appears to me that societally we've created a mess, And our children are the ones that are suffering. And now we're going to the federal government who's instituting these programs that kind of mess up our children to get money to fix them. So if someone can answer those 3 questions, I'd really appreciate it.
Mr. Johansson?
Madam Chairman, Senator Hutchings, happy to address those. In terms of where the federal funding comes from, it's really part of the federal government's general appropriation. So as I was mentioning to Representative Ottman, it's not a specific grant source. It's not time limited. It comes from the same government appropriations that our normal federal match in Medicaid comes from as well. And again, I know we've had this discussion before, Senator Hutchings, that yes, any federal funds are at the end of the day taxpayer dollars for sure. The number 2, in terms of the strings attached, unlike some other federal opportunities, especially in Medicaid, there really aren't policy or operational strings attached to these supplemental payment or UPL programs, other than specifying in our plan and specifying provider types and kind of what kind of providers that are participating in these. So for example, we have some differentiation, Senator Hutchings, between our, as Mr. Boley was mentioning, for example, our private hospitals in these supplemental payment programs and our county-owned or publicly owned hospitals or nursing homes. There's just some technical differentiation in how the monies are assessed and distributed that I wouldn't consider federal strings attached to them in terms of what the state or what the providers have to do or have to comply with, as we see in some other federal grants or opportunities. Third, Senator Hutchings, in terms of the state, doing something like this on its own, obviously that would require state investment. And I would just reiterate here that these types of programs are a tool in the toolbox to increase cost coverage for providers, safety net providers that provide services to some of our folks that are most in need. It certainly is not a comprehensive solution to solve problems, but it is a way with no state investment, with state dollars, to essentially grow the pie. Secondly, Senator Hutchings, I would mention there that, again, your point's well taken on the system of mental health and the system of mental health services for our youth being in jeopardy. And I would echo that. We have a lot of challenges with our mental health system in the state. And I'm optimistic that with some of the reform efforts that this committee and the legislature have authorized for our community mental health reform, for the redesign we did on some of our state facilities, and some other items that are in the works. I think we are actively making improvements to that system. But again, your point's well taken, because this is just a tool. I want to be very clear. This is not a comprehensive solution to our adolescent mental health issues, which are significant and are very challenging for my agency, for Department of Family Services, Department of Education, and your communities.
Okay, any other questions before I refresh or perhaps initially make my motion on the bill draft? Remember, the bill then would be before us. Yes, ma'am.
Madam Chairman, do you mind if I ask a question just to clarify on your motion? You asked, or I guess you were asking LSO for general authorization, and the second was, I just want to make sure that you were asking for authorization to use the existing UPL program funds for the PRTFs. Is that correct? Is that what we were talking about?
The language that I sort of vaguely offered was just to have the bill draft state that it's legislative intention that the department have authorization to spend upper payment limit revenue to draw down federal benefits for the PRTFs. Keeping in mind that if this is to enable us to have in October an actual LSO bill draft, which of course could be amended in October, but we need to have something in LSO form to look at, to vote on.
Madam Chairman, thank you very much.
Okay, because we don't spring fully formed from my mouth to the legislative session, hand from the grave. Okay, committee, in that case, I I would like to move that we ask LSO to draft a bill for our consideration in October, authorizing the Department of Health to pursue an upper payment limit program for PRTFs with CMS, and secondarily to state that it is the legislature's intention that the department have authorization to spend upper payment limit revenue to draw down federal dollars to benefit the PRTFs. Do I have a second? Seconded by Baldwin. Any discussion? Okay, all in favor, please say aye. Aye. Any opposed?
Nay.
2 opposed. Okay, that bill
Three.
passes. So, 3 then. Okay. Less than 11. Okay, so that is managed. Thank you, Mr. Bowley. Director, I suppose you might be up again, so we'll put your name on the seat. Can get you a nice embroidered seat cover, Director Johansson. All right, the next topic on our agenda is to consider the LSO draft to have temporary 12-month postpartum coverage in the Medicaid program. Okay, let's dig that one out, committee. So you have in your packet, it says draft only 23 LSO 0056, Medicaid temporary 12-month postpartum coverage. Who have we got for that? Mr. Johansson, I guess. Okay.
Madam Chairman, members of the committee, again, Stefan Johansson with the Department of Health. At our last committee meeting in June, you all directed LSO to draft a bill related to an opportunity that came out of recent federal legislation in the ARPA Act that allows states the ability to extend postpartum coverage in Medicaid for a 12-month period without having to do a waiver. So the federal flexibility here is being able to extend this postpartum coverage through state plan amendment as opposed to a more complicated waiver provision. As we talked about at our last meeting, what the reason we presented on it is because during the public health emergency, the federal emergency, which is still ongoing, Medicaid programs across the country have been prohibited from disenrolling any Medicaid members during the public health emergency. With this type of option for postpartum coverage specifically, it's given us a bit of a natural experiment since those women in their postpartum coverage have not been disenrolled as they normally would after 60 days in our general Medicaid state plan. So the committee asked for a bill to be drafted that would give us that authorization to extend postpartum coverage in Medicaid for 12 months. There is a placeholder appropriation in the bill. I think it's XXX in the bill, but as we discussed in our previous meeting, the department estimates that extending postpartum coverage in Medicaid, the biennial cost on the state general fund would be approximately $3.8 million with a corresponding $3.8 million of federal funds. That's what we believe our best guess, our best estimate of what the cost would be using that natural experiment we've had, seeing these women on the rolls of Medicaid a bit longer past the normal postpartum coverage period that we have historically had. Madam Chairman, the only small issue I would point out in the bill, it's a bit of a technicality on page 2, lines 7 through 9. It is this this bill or legislation would be repealed effective July 1st, 2027. That provision came from, as you might remember, this is currently authorized at the federal level for a 5-year period ending in 2027. The technical issue here, Madam Chairman, is I believe CMS rule that has come out since this option would technically expire March 31st of 2027. Again, I don't see this as a major issue with the bill. If the option wasn't available at the federal level, we would obviously stop. And I know discussions between now and then will happen at the federal level on whether to extend that or not. But the technical date is March 31st, 2027, as we understand it now. Madam Chairman, members of the committee, again, another quick overview since we discussed it at length at the last committee meeting, but I'm more than happy to stand for any questions. And I believe we have Jan Stahl, our interim Medicaid agent, available virtually if there's specific questions for her as well.
Okay, questions for Director Johansson?
Madam Chair.
Representative Connolly?
Thank you, Madam Chair. Director, could you remind us, with the natural experiment, you gave us the dollar figure, but also how many women would be positively impacted and what would be the health outcomes that would be expected?
Madam Chairman, Representative Connolly, I will have to either use the lifeline behind me with Mr. Fuchs or defer to Jan. I might have to just go look at those materials. I can't remember the estimated number of enrollees off the top of my head.
Looks like Mr. Fuchs is right there. Welcome, Mr. Fuchs.
Thank you, Madam Chairman. Madam Chairman, Representative Connolly, members of the committee, my name is Franz Fuchs. I'm Policy Analyst, Department of Health. To answer your first question, Madam Chairman, Representative Connolly, we expect an increase in monthly enrollment by 1,250, so 1,250. Basically, that would be the increase in the average monthly enrollment. So it's not the total number of women affected, which would be contingent upon the whole, how many would actually enroll and like the length of the thing. But that's basically how much the pregnant women eligibility group would increase on a monthly basis.
To refresh Representative Connolly's question, I think the main reason that we were interested, obviously, is the health benefits. So can you detail that?
Madam Chairman, Representative Connolly, we have been actively working on this question. I don't have a good answer for you right now. We have gotten, when we talked last, we sort of mentioned the difficulty of trying to get that control group information. So all the women that have been disenrolled, well, it turns out we don't actually have health information on them because they're no longer insured by Medicaid. So we were trying to figure out what measures we could use that might be external to Medicaid that would we be able to collect on that group of women. And so we've looked at trying to get data from three sources. One, DFS, looking at DFS involvement as sort of a proxy measure for behavioral health or other, life kind of outcomes. And that would be collected on all, DFS involvement would be collected on all women throughout the state over that time period. So we did receive data from DFS. That's been a success story. Unfortunately, we did not find any significant effects. And that's likely due to a relatively small sample size that we were able to compare. So that was, I can't report anything on that front. We also are actively working with Department of Corrections to try to get an MOU for their data, looking at correctional data. But given the finding of no significant effect on the DFS side, I would be very surprised if there was anything significant on the correction side once we access that data. And then finally, we're also able to get access to the Wi-Fi database, which has very comprehensive data on specifically for Laramie County from 2018 to now. And so we're looking at Laramie County bursts, but that subsets it even further. And again, no significant findings on emergency department visits that might have been uninsured. So I don't really have any good thing to report other than that we actually have been trying to work on this problem. It's just run into some of those issues with data availability and just the sample size being relatively small to be able to distinguish any kind of statistically significant effects.
Okay, we'll hear from public comment before we work on the bill further. More questions for Director Johansson? Yes, Senator Furphy.
Thank you, Madam Chair. Just curious, in the bill draft on page 4, you've got estimated cost of $3.8 million from the general fund and $3.8 million from federal funds. Where did those dollars come from? And do you have an estimate now of, if we start this program immediately, what it would cost the state? Thank you.
Madam Chairman, Senator Furphy, the numbers come from what we estimate to be the growth in enrollment, because traditionally, even though it's different during the public health emergency right now, since we can't disenroll anybody, traditionally our Medicaid postpartum coverage is a 60-day postpartum coverage for that group of women. The estimates that you're seeing in the bill draft and in the presentation from June come from what we estimate, if the extension was authorized, to be the growth in enrollment in that postpartum coverage category on a monthly basis, and then multiplied by an estimated per member per month cost of what the utilization looks like in the postpartum coverage group. That's where the 3.8 million of general fund cost estimate comes from. And of course, with Wyoming Medicaid, it would be matched. It's a 50-50 cost split, so 3.8 million of federal funds as well.
Representative Stiver.
Thank you, Madam Chairman. Has there been any analysis done of what other programs that, you know, once they qualify for Medicaid, there's other programs out there that they're going to continue to be able to draw from? Has there been any analysis of what it's going to cost them other programs?
Director.
Madam Chairman, Representative Stivar, simple answer is no. There's nothing that prevents any of our enrollment groups from enrolling in or taking advantage of services in other programs. Demographically speaking, Representative, with this particular group of women that would potentially have this coverage extension, there's likely other state, federal, and local programs that they benefit from as well. But our analysis is specific to the Medicaid side, the Medicaid population.
So Director, just on that, so are you saying that there are no programs that people are specifically made eligible for just because they're on Medicaid?
Madam Chairman, yes, that is a good clarification. There would be no other automatic eligibility triggered for this group by nature of having this coverage extended.
Did you have a follow-up, Representative Stiver?
Follow-up.
Mhm.
And you said the new date would be March 31st, 2027? What about the maintenance effort that's going to go along with this?
Director.
Madam Chairman, Representative Stivar, there's no maintenance of effort provision in what was authorized by Congress in this option. But to be clear, this does come with the need for state finances based on our federal match rate.
During that time period?
Correct.
Right.
Follow up.
Mhm.
Get this one out here. Madam Chairman, Pregnant by Choice program that's out there now that most women take after the 60 days. Is it going to affect that, or is that still a viable program still going on?
Director.
Madam Chairman, Representative Stivar, if I may, I'd like to defer that to our interim Medicaid agent, Jan Stahl, if she's available and can
Yes,
unmute.
I see her. Ms. Stahl, welcome.
Good morning. Representative Stiver, Madam Chairman, we would not expect to see an impact to our Pregnant by Choice program. That's a very small program for us at this time. We're serving probably not more than 20 to 30 women a year through that program. So we wouldn't expect that this would impact that program.
Okay. Any more questions? Representative Connolly.
Thank you, Madam Chair. Directors, I appreciate you trying to find data about what would happen. And honestly, even though 1250 is a big number, it would certainly be my hope that few of them would be part of programs by DFS or, God forbid, DOC, right? Because that would mean that they're in big trouble. But can you talk a little bit about what you know in your positions in the Department of Health about the importance or the relevance of postpartum care for newborns from 6 months to a year, from 6 weeks to a year? Is it valuable?
Madam Chairman, Representative Connolly, as we discussed in our June meeting, absolutely. The real logic behind the federal government putting this option at 12 months, and a big part of our discussion was why 12 and not 6 or not 3, is really in looking at maternal mortality, that having postpartum coverage in that time frame does have significance in eliminating complications, death, et cetera. As Franz mentioned, we do have a very low sample size in Wyoming, so detecting effects is difficult. I would mention and clarify for the committee that one of the benefits of any coverage extension, and I know the debate is, should we do this? Should we increase state and federal costs? And it's a reasonable debate. But anytime we talk about Medicaid coverage or other insurance coverage on the financial side, health insurance is beneficial to individuals, especially graded at the lower income spectrum, because healthcare costs can be so unpredictable and sometimes so detrimental to someone's personal finances. So to be clear, while it's difficult right now for us to detect, health and human services benefits statistically, it does go without saying that coverage extension, whether that's through public sources or private sources, Medicaid, the insurance exchange, et cetera, having that ability to cover healthcare costs is certainly a benefit to individuals on the financial side.
More questions? Representative Ottman.
Thank you, Madam Chairman. What I'm wondering is, with all of this, and I'm sure some of these things have been already reiterated, but going through to 2027, so if there's people that begin the program in January of that year, then that would still be extended through that, is the first question. And then after that, we see here that the date is a placeholder. I'm not in the hospital field, but I honestly am not aware of a large group of people that have postpartum problems into 10 months and that with death. So is that 3.8 million, is that per year, per biennium, and all of those things? I'm just wondering. And then also, would it go to a particular program or a particular place, or just to the Department of Health to be distributed as needed? Or, so if you could clarify, thank you.
Madam Chairman, Representative Ottman, a couple of questions there, so you might have to help me remembering all of them. The $3.8 million figure is the state cost on a biennial basis, $3.8 million for 2 years. That comes with a $3.8 million federal match, but the state cost would be $3.8 million for a 2-year budget period. To your first question about if the feds have authorized this option through March of 2027, and if someone enrolled in January, would that 12 months still hold, I think was your question. I don't know the answer to that. Ms. Stahl might be able to clarify if there are any rule clarifications from CMS, but typically if a program was going to end at the federal level, we have requirements to notify members of whatever eligibility group might be ending with advance notice, so that process would take place. But Jan, I'm not sure if that's been clarified at the federal level, but we might have to research that.
Ms. Stahl?
Thank you, Madam Chair. I'm actually researching that right now. I have not seen that question before, but we will see what we can find on that and get back to you.
So just at the very basic level, the person would go back to the 2-month postpartum coverage. I mean, that is existing now. So that's not that they would get no postpartum coverage. We have an existing 2-month postpartum coverage program. So at the least, they would have that. But I'm not CMS. Thank God for that.
Follow up, please.
Follow up. Mm-hmm.
So what we're looking at then basically is 2.5 bienniums at 3.8 million. That's right.
Madam Chairman, Representative Ottman, yes, and obviously all of this is, when it crosses biennia, is subject to legislative appropriations. And so I'll be clear that in terms of state plan amendments, legislative authorization for us is not necessary. Obviously, if there's an increased appropriation, legislative authorization is. As I mentioned on the previous topic, my preference when we do any sort of extension or expansion of coverage is to have these legislative discussions to get that appropriate authorization. The federal option goes through 2027 right now. If the extension were passed, if this bill were passed, that would be put into our standard budget as written. So the $3.8 million would carry over to that next biennium. What's uncertain is if the feds would extend this option beyond 2027. And we would come back to this committee and the legislature if that were not the case, and plan accordingly.
More questions for Director Johansson? Anyone online? Trying to remember you all up there. Thanks for being here online. Okay, is there any public comment on this bill? Come on up, line up. We've got 4 seats, nicely warmed. Well, the other ones were pre-warmed. They're tepid. Right.
Madam Chair.
Representative Connolly.
Madam Chair, just because we can, to answer Representative Ottman's question about the maternal mortality rate in Wyoming, pulled up 2 websites, one for, we were 39th in the nation. In 22, we were 38th in the nation in 18.
Is number 1 the best or the worst?
Number 1 is the best.
Okay,
So
so
we
we're
are
in the
at the
bottom half.
We're in the bottom, we are close to the bottom.
Representative Ottman,
Okay, we're 38th, but what,
in maternal mortality rate, she said.
And Madam Chair, that means 28 deaths per 100,000 births or 100.
Which of course isn't that many deaths. I
It's
mean,
not
we
that
can't
many
possibly
deaths,
have
but-
100,000 births in a year, but
okay, thank you.
welcome.
Good morning, Madam Chairman, members of the committee. My name is Mary Lynn Shickich, and I'm representing the Wyoming Primary Care Association. It's an organization that is the nonprofit community health centers that provide services to those who have no resources to pay or can pay on a sliding scale. They are spread throughout the state. They're not in every community. They're not located. There's a school-based center in Campbell County, but there's not a health center per se. There's several in Cheyenne and Casper. There's one in Evanston. There's one in Laramie. They basically provide care to those who, anybody can utilize their services, but they're called federally qualified health centers. We're here today asking for your support of this bill because we believe the care that's provided at the first stages of life are some of the most important care that can be provided that will impact the rest of a baby's life. It's well known and it's documented that the first 5 years of a baby's life are the most important in terms of his or her brain life, and that what happens later in life is very much dependent on healthy weight in babies, correct nutrition in babies, and the prevention of any kind of early diseases. So while we're not sure of exactly this timeline, I think for a Medicaid mother, this 12 months of postpartum health care would be very valuable for the long-term care of a baby's life. With that, I'll turn it over to my colleague.
Actually, I have a question first. So just to be clear, so the child's coverage under Medicaid is not contingent upon the mother's postpartum coverage. So if a baby were eligible for Medicaid, the baby would still be covered. So do you have is there something you want to say more about the benefit of the mother receiving care as far as how that rolls over to the baby?
The first several years of a baby life is very much dependent on its mother's or a major caregiver. So that child's health and welfare is really dependent on the mother having coverage as well and be available to the child. So I see it as going hand in hand. That relationship between the mother and the baby is essential for the baby's life.
Okay, thank you for that clarification. Okay, hello, Ms. Brochus.
Good morning.
Introduce yourself if you would.
Good morning. Thank you, Senator or Representative Wilson. I'm Tracy Brochus. I am the CEO at HealthWorks, which is one of the community health centers. But on behalf of all of our members, I would say that this particular situation with our mothers at this point in time, especially in the post-pandemic timeframe, we have seen a dramatic uptick in the mothers struggling with that post-pandemic and the stress. The stress during this time has really increased the access for a lot of these moms coming for mental health services. So while it may not necessarily be direct, like what you would think of as primary care, a lot of this access is in the mental health sphere, substance abuse issues, ongoing, that stress of being a new mom, in addition to all the rest of the stresses that they have experienced. So my mental health counselors would stress that this is a very critical time, not only for those moms, but for those children to have access. Keeping in mind, if these moms do not have access to care, and the health insurance piece being the major piece of that access, those moms now go into the sliding fee scale world, and we would continue to serve them. The challenge is if we cannot serve them in the clinic and they go to a hospital, right, for something more serious, then they have the challenges and the barriers of that uncompensated care at the hospital level. So we have recently run some comparisons with the way we offset that uncompensated care at the clinic. For every hospital visit that they visit the ED in Cheyenne, the cost just to come through the door for an ED visit is $1,500 just to go through the ED. We can treat those patients in the clinics at a much lower level. And if they have health insurance through the Medicaid program, that is an immediate benefit to them because they already have an established relationship with a care provider. So they can come and continue to seek care with the folks that they've already been being treated from for, during their pregnancy and for their kiddos. So.
Questions for Ms. Brochus? Representative Connolly.
Yeah, thank you, Madam Chair. And I'm going to ask you, it'd be anecdotal and from your own experience, but let's say, we're talking about, for the most part, young women who were Medicaid eligible and will no longer be. How much would it cost them to come in and not to an ED, but to you, and get the kind of care that they were getting when they were Medicaid eligible? And so for me, I'll just personally, right now I'm getting PT, right? I get PT. I wanted to know how many sessions I get before I have to pay out of pocket, for example, right? It's going to make a difference to me, even me who's got a good income, right? The difference between my copay and $100, that's something I'm going to think about. So I'm curious, with these women who are per se poor, getting Medicaid coverage, what would be the cost to go into your clinic, right, when they are no longer covered, even at a sliding scale?
Ms. Brochus.
Thank you, Representative Connolly. That is a very valid issue. With the copays on the Medicaid side, for example, if they were to come for ongoing mental health counseling, that would be an ongoing, potentially weekly or at least monthly visit. The Medicaid copay for that is $3, for example, $3, and I can't remember the exact, so let's say $4 and round it up. If they were on our sliding fee scale, that's probably more like $35. So while it is still, in most cases, would be on a sliding fee, it's reduced from the cost of what it would be in a private organization. It's still that significant jump, especially when you have reoccurring appointments. And if you're struggling with something like substance abuse or severe depression in that postpartum section, they could be, the counselor may suggest them being seen once a week. So then we're talking, a couple $100 a month for just the mom to seek treatment. And so that's the concern. This is what allows those moms to continue to seek treatment in that really critical phase of especially in the kid's life in the beginning.
Representative Ottman.
Thank you, Madam Chairman. Hi. What I'm wondering, because anytime somebody's struggling, we would like to help them. But what if, and I've been reading about this too, what if the majority or a lot of 80%, I think I read 79% is mental health related because of stress and anxiety? How can coming to your services alleviate that stress? Thank you.
Ms. Brochus.
Yes, Representative Ottman, the mental health services teach coping mechanisms for, in this case, those new moms, right? How they can approach life when everything is, vastly changing for them, potentially with a new child or an additional child in their world. So that mental health treatment is really giving them the tools to approach their life and figure out that stress mechanism and those coping mechanisms. I'm hoping that's answering the question with someone that is trained to help coach them through that, so that counseling function, along with the primary care.
Branching out a little bit further with the question earlier about the mortality and all, would we say up in Fremont County where there's a higher incidence, I assume, of diabetes on the reservation, is if a mother is diabetic, is there a postpartum problem? I mean, let's think, if you can talk about some of the physical problems that a person might have had previously anyway, that might be continuing. Can you talk a little bit about the health situation?
Yes, Chairman Wilson, while I'm not a clinician, and I want to be real clear with that, this does compound. It's a compounding function. If they have a pre-existing condition like diabetes, there's the additional pieces of now having their medications, the management. It's a very huge change in your biology to have a child, which may need that ongoing, and I'm sure Chairman Baldwin could really speak to that much better than I can.
Chairman Baldwin, would you like to give us a short tutorial about postpartum diabetes?
It'll be short. I don't know how much tutorial it is. Two things that came to mind when you mentioned that is sometimes we discover things through pregnancy, a disease process that woman didn't know that she had to start with, diabetes being one of them,
Right.
thyroid condition, et cetera. Dr. Halloran can throw in here if he'd like. But sometimes we discover new diseases that women didn't know that they had. So in addition to the new child, now they have diabetes, now they have thyroid, whatever the disease is. So they got new medicines, new things they have to learn on top of the pregnancy. And I don't know the statistic off the top of my head. I wish I did, and I should learn it. And the amount of postpartum depression, which is tremendous. It's a huge number. But if you add on top of that these other diseases, if they already know they have a disease, and we use diabetes as the example, it complicates it. It compounds it for at least a time period after the delivery, that things get more complicated than they were before the pregnancy ever started. So it's an additional stress. Sometimes it's a new stress and not only additional. So there's a significant change with the pregnancy and with the postpartum periods.
Thank you. Okay, any more questions for Ms. Brochus or Ms. Shikish? Okay, is there any other testimony on this bill? Oh, good. Thank you for reminding me. Who do we have? I think I might have them on my list. Okay, who do we have first? Welcome. If you could introduce yourself for the committee and let us know what you're thinking about.
Good morning. Good morning, Madam Chairman. My name is Ariel Bernath, and I'm the Wyoming Engagement Manager with the American Cancer Society Cancer Action Network. I'm also a resident of Laramie, Wyoming. And I'm here today because the American Cancer Society Cancer Action Network supports the bill to extend Medicaid eligibility to people who have given birth within the preceding 12 months. Ensuring that low-income individuals and families continue to have access to affordable health coverage during the postpartum period is one of the most critical ways that we can reduce cancer incidence and mortality. And we know that preventing cancer is much less expensive than treating it. And in the period after giving birth, we also know that cancer risks are actually heightened from their baseline. An additional 12-month period of affordable, accessible health coverage allows for more time to diagnose and treat health issues, including cancer, and that may have been identified in the course of a routine pregnancy and postpartum care. Improving cancer diagnosis and survivorship after a pregnancy is not just important to postpartum women, but it's also important to their babies and to their family units. So while the most cost-effective solution to improving the lives of all Wyomingites, including those at risk of and in treatment for, or those who have survived cancer, is to fully expand Medicaid up to 138% of the federal poverty level, postpartum extension of Medicaid coverage represents a positive step toward improving health for Wyoming families. So the American Cancer Society Cancer Action Network urges the members of this committee to support healthy Wyoming families and passes legislation to extend eligibility for our state's Medicaid program to people who have been pregnant within the preceding 12 months. Thank you for your time.
Thank you. Any questions for Ms. Bernath? Okay, thank you. Let's see, is Ms. Smith-Hazelton on?
Yes.
somewhere. Oh, here we
Hi.
are. Hello.
Hello, my name is Rebecca Smith Hazelton, and I'm the director of the Wyoming Women's Foundation. And we support this bill, and I wanted to take this opportunity to have a colleague of mine in the room, Marissa Carpio, who's our advocacy coordinator, pass out some data that recently came out through our parent organization, which is called the Wyoming Community Foundation, and give that information to you and then just go over it briefly. So do I have the opportunity to share my screen so that the audience can see this as well?
Can we have that happen, Ms. Donna? Okay. Do whatever you need on your end.
So this is the Wyoming Kids Count publication, which came out just really recently here, and it's put out by the Wyoming Community Foundation, which is the Wyoming Kids Count grantee. And so the Community Foundation as a whole also supports this bill. And we have provided you with an excerpt that starts on page 45, and it describes the benefits of the postpartum extension. And one of the reasons that I wanted to share this is so that we could address some of the questions that came up from the Representative Ottman, I think, asked about the maternal mortality. And we do have some information on that in this publication. Hopefully you have that in front of you now and are seeing it on my screen.
Yep, go ahead.
And so according to the most recent data from the CDC, which is from 2020, 1 in 10 deaths are occurring between 6 weeks and 1 year postpartum in Wyoming. And 3 in 5 pregnancy-related deaths are preventable. I also think it's important to note that there's been an increase in maternal mortality recently as of 2019. And then on the next page, there's some data here on, sorry, let me move that so you can see that. There's some data on claims made because Wyoming extended postpartum coverage. And so 561 women made mental health claims and 31 women on Medicaid for postpartum coverage made serious medical condition claims. And I also wanted to note the recommendation that women have at least 2 follow-up visits after birth, and one of them being after that the current 60-day period. So that's the bulk of it, and I can answer any questions.
Okay, questions for Ms. Smith Hazelton? Is there anyone online? You're kind of covered by the screen, so anybody online have a question? Just call out if so. Okay, no? Okay, thanks very much. Thank you for the handout. Sadly informative. Okay, do we have, Donna, is Marguerite Herman on as well? No. Well, it says Medicaid coverage postpartum. Okay, hi there. Come on, introduce yourself for the benefit of the committee, please.
Good morning, Madam Chairman, members of the committee. My name is Lindsay Simoneau. I represent the Wyoming Counseling Association. I would like to really echo and thank my colleague from HealthWorks. She did a lot of my testimony for me. So very much echoing a lot of what she said. We do see a lot of the mental health issues and postpartum issues after the 8-week period as far as mental health providers, whether that is postpartum depression, postpartum psychosis, as well as substance use issues. We have seen an uptick in that because of the pandemic and the stressors that have come along with that. By extending this to 12 months, we are opening the chance for pregnant women or for postpartum women to engage in those mental health services and engage in that continuity of care, which is vital for those moms to be able to provide those stable environments for their new babies, especially living in a rural state. because of the distance between families in Wyoming, it's not always as easy to rely on grandparents, aunts and uncles to help within the first year of baby's life. And so mental health services for mom gives her that needed additional mental health support to be able to provide that stable environment for that baby. Also, by extending it to 12 months, we give mom the opportunity to find employment to extend her own private insurance coverage, if with that being a possibility. So then she doesn't have that gap in care from the time that she delivered to finding new employment with insurance. And with that, I stand for any additional question. On an anecdotal note, as a private provider, from my own experience, for Representative Connolly's information, my self-pay for somebody without Medicaid would be $75. I think you would find that many within the private provider field are around that same number, or lower, possibly to that 50 scale. For new moms, for a mom who just had a brand new newborn, $50 a week, $75 a week is unfathomable to put into the budget while caring for this child. And therefore, I think that this Medicaid expansion for new moms would be vital in continuing that mental health care.
Great. Questions for Ms. Simoneau? Thank you. You know, am I here? Ms. Ottman, or Representative Ottman, yes. Sorry.
Thank you, Madam Chairman. You know, what I'm wondering is, there's been lots of things go on over the years with different boom and bust cycles and things that we go through here. We have done nothing for postpartum moms over the years, and so this is addressing a problem that's never been addressed before. Is that what I'm hearing?
Ms. Simoneau.
Madam Chairwoman, Representative Ottman, correct. This interim topic is not just in this committee, as the legislature knows. It is also something that Judiciary is considering as well, of how do we address the issue of postpartum moms, pregnant women. And so it is something that is not just a concern for this committee, but for the state as a whole.
So just to be clear, they are currently covered for 60 days. It's been that way for a long time. But after 60 days, no, we don't do anything. Thank you, Ms. Simoneau. Okay, and actually, Ms. Shikic or Ms. Brocious, I just thought of a question, and I'm sorry, it is a little bit of a clinical one, but I came up with a question later. Just thinking of if the mom were nursing and we're struggling with that, as I've certainly known some young mothers do after the 8th week. If the baby comes in and the mother's not covered, does she have access to any kind of lactation counseling? I mean, it's not really considered a baby visit coverage thing, is it? No. Okay. Just wanted to clarify that. Representative Ottman, now you're out of people to ask. You'll have to just posit it to the air. We'll call upon the appropriate target in the back of the room.
Yes, and just a thought, in our community, it has been available and not always widespread as far as information goes. But I'm wondering, with the pregnancy help centers, they have classes on these things and help women through pregnancy, through adoption, through lactating, through whatever it is. And of course, they're expanding as data comes out and shows the real needs of mothers. But do the mental health providers work with the pregnancy help centers, or are you even aware that that's an option or an opportunity, and they would be at no charge?
Ms. Simoneau.
Madam Chairwoman, Representative Ottman, for clarification, do you mean the nonprofit pregnancy centers that we see around the state? Madam Chairwoman, Representative Ottman, what I would say to that is many of them are nonprofit. There aren't many licensed providers that work directly. A lot of those are non-private or not profit workers, employees. I am sure, I can speculate, that there's probably a licensed provider within a pregnancy center at some point in the state of Wyoming. I can tell you that the one in Cheyenne does not have a licensed provider. You are going to see those licensed providers primarily in the state of Wyoming within private practice or within the community mental health centers. I'm just going to stay here in case you have something else.
I would think that that would, the ability of the pregnancy centers to help would depend on the severity of the person's problem. You know, I mean, if you can be counseled by a person like me or you as a friendly person coming alongside, that's one thing. If on the other hand, you need psychiatric medication, that's obviously beyond our scope.
Right. Follow
Right.
up, please. Madam Chairman and Lindsay, thank you. And this is a whole new field, I realize that. But currently, what I'm learning is that the centers are under an actual license, and that there are nurses and different things in these centers to help. And if it is anxiety and stress related, and if that's a large portion of it, which I'm seeing, like I said, about 80%, sometimes, you know, the help of people that deal with that day in and day out is sufficient for a person that can come in daily if they need to, or weekly. And so I'm thinking, you know, it would be nice to be able for the communities to work together to whomever could provide at whatever, because it doesn't always have to be, because I know our medical providers there with Fremont Counseling and stuff, they're backlogged. They are so backlogged. So it's not like you're having a problem right now and that you can get in to see somebody. So I'm just thinking if that could be a thought, or if we could get more educated on available services in communities rather than just through Medicaid. Thank you.
Madam Chair, Representative Ottman, absolutely. I think siloing is always an issue in Wyoming, and breaking down those silos and making sure that we are working together statewide and working together as a community to serve this population is essential in addressing these issues. I think the decision that we have for today, as far as expanding Medicaid for that postpartum population, is another tool in the state's toolbox so that those postpartum women can engage in a pregnancy center if they are unavailable or their mental health needs are larger than what that pregnancy center is able to handle. Then they have the option to get that mental health care from a licensed provider, whether it is private practice within the community or at a community mental health center or at a group center as well.
Thank you. Okay, any more questions? Any more public comment on this bill? Come on up. Welcome. Introduce yourself, if you would, for the benefit of
Good morning,
those in
Madam
TV land.
Chairman, members of the committee. My name is Sheila Bush. I am the Executive Director for the Wyoming Medical Society. We represent physicians and PAs across the state. I wanted to just offer and make sure, so from the data that the Department of Health provided, you can see pretty clearly that a disproportionate amount of the claims are mental health related, which is why the focus has shifted that direction this morning. I will offer that in all of my time advocating within medicine, one of the hardest things to prove is the value of preventive care. We work really hard to figure out a way to do that, and it's incredibly difficult to put on a graph or to give you a picture that says $1 spent in preventive care is this many dollars saved. There are too many variables and factors, and so sometimes when we lack the graph to show you, a story can maybe paint the picture best. And so I guess what I always think about when I think about this issue is a family, or, you know, in my case, when I had children, I had a huge support network. I had a loving husband and parents on both sides. I had a lot available to me. And so when we brought an infant home and the stress that brings and the late nights and the sleeplessness, I had a huge network. And so in a lot of ways, we're talking about a community where they may not have that. And so if you have a woman who has a pregnancy, she takes home an infant, the data suggests that 42 days is when the best screening time is for screening for mental health. So that's 6 weeks. 42 days is just 18 days short of the 60 when they lose any sort of access to help. And so if at that 42 days, something is identified or diagnosed, they have 18 days to find a treatment plan or get help, and then that's not available to them anymore. And so the story I would offer is a mom with a brand new infant without the same support network I talked about. If one individual in the state of Wyoming gets to a peak of stress and maybe shakes a baby, which we know is a problem, that is a long-term potential brain injury. And if it's bad enough, that's an incarcerated mother. And then the state pays all of that, right? We pay for the mom to be incarcerated for whatever duration is deemed appropriate, and we pay for the injury to that child for a lifetime. And so whatever cost is associated with this extension of coverage, I would argue is easily covered and overshadowed by the cost of just one situation like that. And so again, sometimes preventive care is the hardest to prove in data or a graph. But if you think about these situations and we think about what we're really talking about, we're talking about a nominal amount of money to extend this coverage. There's mounting evidence to support the value of it. And so we would just, on behalf of the Medical Society, ask for you to really think about those things before you vote in how important this could be for families in Wyoming.
Questions for Ms. Bush? Any online? Nope. Okay, thank you very much. Any more testimony on this bill? Come on up. Mr. Hennis, if you will introduce yourself for the benefit of the committee.
Oh, good morning. Josh Hannis with the Wyoming Hospital Association, Madam Chairman, and members of the committee. I'll be very brief. I would echo the supportive comments of previous speakers and would just reiterate too that while mental health has been a focus, that these women postpartum have access to the full suite of Medicaid benefits for those 12 months. So as Senator Baldwin pointed out, if there's a chronic condition to be treated, these people have access to the medications they need, the treatments they need, and access to care. As you've heard us talk about many times, access to care is a critical component of people's health, and insurance is an important part of that. Particularly with this population, pregnancy being one of the most dangerous times in a woman's life, we find it incredibly important for them to have access to primary care, to the physicians and specialists that they need. And in addition, and I think it was pointed out earlier, is that there's research to suggest and, well, frankly, to demonstrate that a woman having access to care and maintaining her health leads to better outcomes for that child and for her children. So we would ask that you support this moving forward, and I would stand for questions.
Questions for Mr. Hennis? Okay. Any more testimony on this bill? All right, then public testimony is closed. Do I hear a motion on the bill?
Move the bill.
Moved by Conley. Is there a second? Seconded by Furphy. Any discussion?
Question.
Actually, hang on. I have, and we need to amend it a little bit. Oh, Senator Hutchings, did you have discussion?
I'll let you go ahead and deal with your amendments.
Okay. So the first amendment that I would move is on page 2, line 9. Strike July 1 and insert March 31st. Is there a second? Second by Connolly. I don't think that needs any discussion, really. All of those in favor, please say aye. Aye. Any opposed? Okay, that passes. And then the second amendment would be on page 3. We need to amend the XXX. I don't think that's a dollar amount that appropriations committee will accept. So I would, on line 19 and 20, and actually 18, 19, and 20, for the XXXs, substitute $3.8 million in the appropriate script. And it's seconded by Baldwin. Any discussion? Okay, all in favor, say aye. Aye. Any
Aye.
opposed? No opposed. Okay, so that amendment passes. Okay, those are the amendments. All right, discussion. Senator Hutchings.
Thank you, Madam Chair. As most of you would probably suspect, I'm in total opposition of this expansion. One of the things I know we all know is once you start a government program, it never goes away. And that's what I see here. We started something that was not within our constitutional purview to start. And now we're trying to expand it, extend it. And I always ask the question, and even with the last topic of conversation, where is the money coming from? Are there private sources like the Life Choice Pregnancy Centers that can deal with this situation? We have federal government ties in everything we do. But basically, this bill, this extension, this increase in cost to our state, to our citizens, is not authorized in our Constitution. So I'm going to be a no vote. Thank you, Madam Chair.
Is there any other discussion? Representative Hallinan.
Thank you, Madam Chairman. I have an amendment to offer.
Okay,
It would be to replace the amendment that you recently put in place.
which page are you on?
And I would say that on line 9 on page 2, I would like to substitute July 1, 2023. And the reason for that, Madam Chairman, if I may,
Okay, actually, is there a second?
I'll second.
Seconded by Stivar.
the main reason I don't think that I feel that I'm comfortable in spending money until 2027. I think that our legislature should look at this bill after 1 year and see if they want to continue it. So I would change that to 2023 on that line. Thank you, Madam Chairman.
So I will note that on page 4, line 21, the bill is only effective July 1, 2023. So your amendment would repeal it the same day that it's effective.
Well, I guess I would say I would have to change that, Madam Chairman. I would say that maybe 1 year after that date would be 2024. Thank you, Madam Chairman. So I'd substitute 2024 for 2023.
So your amendment would be on page 2, line 9, July 1, 2024?
Yes.
Okay. Any further discussion on the amendment? All in favor, say aye.
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 Any opposed? No.
No.
No, sorry, that fails. Okay, any more discussion on the bill? Okay, question on the bill, and I'll just ask, just because it's a little hard to hear over online, if I could have hands, please. All in favor of? Oh, it's a roll call anyway? Okay, go ahead, sorry. Call the roll, please.
Madam Chairman, this is a roll call vote for 23 LSO 0056, Medicaid temporary 12-month postpartum coverage. Senator Furphy? Aye. Senator Hutchings?
No.
Senator McEwen?
No.
Senator Wasserberger? Aye. Representative Brown? Excused.
Excused.
Representative Connolly? Aye. Representative Flitner?
Aye.
Representative Hallinan?
No.
Representative LeBeau, excused. Representative Ottman? No. Representative Stivar?
No.
Representative Worf? Excused? Co-Chairman Baldwin?
Aye.
Co-Chairman Wilson?
Aye. Okay, 6-5. And by the way, so this is the first bill that we've got on our pocketbook for the next session. I think, Senator Baldwin, that you and I should probably hold off until about December to decide which bills will be handled where. About half of the House committee, at least, is not coming back. We need to know who's where before we assign the bills. So we'll, LSO, will be paid pending on that. Okay, folks, I think we could stand a little break here. Let's see, lacking a clock in the room. It's 10:22. Let's come back at 10:30. Donna, looks like we have enough back. Are we ready to go? All right, welcome back, committee. Next topic up for our 9:30, as always, delayed, here we are. Organ donation, insurance coverage and process. That's just a warm up for our afternoon topic about coroners, the Labor, Health, Social Services and Death Committee. Okay, LSO statutory overview of organ donations. So that'll be the first one, I guess. Or you're not LSO.
Good morning, Madam Chairman.
Are we going to hear from LSO first? That's, oh, yeah? Okay, we'll let them, they're on the agenda first, so I'm just going to let them go first. Okay, go ahead, whoever we've got.
Thank you, Madam Chairman, members of the committee. I have a memorandum entitled Organ Donation Procedures and Coroner Duties. This memorandum provides a summary of Wyoming organ donation statutes. Wyoming statutes govern the administration of the donation process and regulate insurance company practices and coverages.
I'm sorry, just for a moment. So I have here one that is from Elizabeth Martineau. Is there another one? I'm not.
There is one from 2022 dated August 4th, 2022. Oh, it was passed out this morning.
Oh, this morning.
And that's what I'm going to be focusing on.
One moment. Okay, all right, got it. This is what we're looking at. Should be in your little pile from this morning. Okay, go ahead, Ms. Johnson.
Thank you.
Thank you. Sorry about the delay.
There are 3 different sets of statutes in Wyoming statute that govern organ donation and organ donation issues. The first is the anatomical gifts and organ transplant statutes. These statutes prohibit denial of organ transplantation coverage for people with disabilities by health insurance issuers. Under these statutes, insurance companies can't deny coverage, eligibility, or reduce coverage for the purpose of avoiding the non-discrimination requirements. Also, health insurance issuers cannot be required to provide coverage for any medically inappropriate organ transplant, but the statutes don't describe what that is. Case law doesn't have any information regarding that either. The second act is the revised Uniform Anatomical Gift Act, and this act describes the organ transplantation process in detail. It specifies who may make an anatomical gift and what the process is to make such a gift or how to refuse to do so. It also outlines permissible purposes of anatomical gifts, such as for research and education, a gift to a medical school, or a donation to any appropriate person for transplantation. It describes the rights, duties, and manner of coordinating donations by organ procurement organizations, or OPOs. OPOs must cooperate with Wyoming coroners, and this act says nothing about funeral directors. Also under this act, it's a felony to sell or purchase a body part of a deceased person. Falsifying documents related to an anatomical gift is a misdemeanor. And if you're acting within the scope of the act, you're immune from civil or criminal penalties. The act also outlines requirements of donor registries. You must include relevant info that must be in the registry, how that information is transferred to procurement organizations, and the information must be accessible to all procurement organizations. The act is also the only part of Wyoming statute that describes the role of coroners in the organ donation process, and it says nothing about funeral directors. Coroners can release medical records to procurement organizations. They can also examine bodies before release to these organizations. And any kind of recovery of an anatomical gift is solely under the coroner's jurisdiction. The coroner can also refuse to release a body or part of a body if he believes it will interfere with postmortem investigation. And then finally, we have the Non-Discrimination in Access to Anatomical Gifts Act. And these statutes prohibit any covered entity such as a healthcare provider and entities responsible for matching donors and recipients from deeming a person with a disability ineligible to receive an organ transplant or to receive care relevant to organ transplantation. The statutes allow for expedited civil actions when insurance companies do not comply with these statutes. And again, covered entities are not required to make a recommendation for a medically inappropriate organ transplant. And with that, I will stand for any questions.
Okay, questions for LSO? We will obviously hear more, but thank you very much for that summary. Okay, then second, we have on the agenda, Department of Insurance. Do we have someone from Department of Insurance? I don't know. Are they online?
I spoke with two of them on Tuesday.
Oh, okay. I didn't realize that she was from Department of Insurance. Okay, do we have Ms. Inshaw? Yes.
Hello. Apologies.
Hello, welcome. Introduce yourself for us if you would.
I am Mavis Earnshaw. I am the Senior Health Planning Analyst for the Wyoming Department of Insurance. I work with all the health policies, and I'm just here to discuss quickly, or not quickly, but to discuss the health policy process with you.
Okay, give us a try.
Okay, Madam Chair, it's important to note that insurance isn't one size fits all. With homeowners insurance, each person would have basically whatever they choose to insure in their home, and they can add additional parts of their insurance for expensive jewelry, antiques, and things like that. Health insurance is no different. The policies vary based on coverages. We have accident only, major medical, hospital indemnity, and others. They are also different based on type. So group disability insurance does not allow any kind of underwriting. So there would be no exclusions, and no one employee would be charged more than any other employee for their insurance based on coverages. The differing costs in employee group insurance is whether they have a dependent and how many dependents they have. In group insurance, the employee chooses the coverages. Not every employer is going to choose the same benefits, and many group policies, their employers do not choose organ transplant. Individual disability or health insurance, on the other hand, is underwritten. There are medical questions and people can be excluded. The insurance department regulates the provision of the policy, but we do not regulate the coverages or the benefits. So again, a person could choose to purchase a major medical plan or an accident only plan, a hospital indemnity plan, or just a critical illness plan. Not all plans are going to offer organ donation as a benefit. A major medical plan or qualified health plan requires essential health benefits and do include organ transplant coverage for the recipient. Most Wyoming carriers for qualified health plans include some sort of donor expenses. When an insurance policy includes organ transplant coverage, it is only covered if it is deemed medically necessary by the insurance company and a physician. The process and requirements of medically necessary are strict and regulated by the Department of Insurance, as are the appeals process if it's found not medically necessary by the company. Life insurance, for the most part, is based on the individual's current health and health history. That's how they set their rates and decide to whom the policies will be issued. A person that has donated an organ may be told they can't purchase or cannot receive a life insurance policy for another reason other than, for example, only having one kidney. They may tell the person that they're denying coverage for family history. They may tell them they're denying it for something else that they would maybe found in their medical questionnaire. The life insurance companies aren't going to come out and say, we're denying this for previous organ donation. And with that, we'll stand for any questions.
Okay, I suspect that we will like you to hang around because probably more of our questions will come up as we get towards further testimony. But any questions for the moment? The main issue on this topic, remember, coroners is kind of a separate issue this afternoon. Right now, we've got, I think, two separate things. One will be the bill that Representative O'Hearn is going to talk to us about, and then the coverage, the statutory issue with the funeral directors is also a separate thing. So we're going to have to kind of keep the plate spinning in our head a little bit on this insurance coverage. So we'll just sit right there. Don't go away. All right, so that having sort of set a vague kind of stage, although perhaps a little hazy, I think probably our next, we have here Representative O'Hearn waiting so patiently. Committee, you have in your stack of the original packet, House Bill 120 from last year. And I presume that Representative O'Hearn is going to talk about it. Go ahead.
Thank you, Madam Chairman. And esteemed committee members, I'm Representative Kevin O'Hearn, bringing you House Bill 120 and ask for your favorable consideration today. I am accompanied here today with Ann Bina to discuss the bill. Ann, a constituent of mine in House District 59, asked me to bring this legislation to you all, as 20+ other states have already adopted such legislation in their states. This legislation was written for me by our LSO staff and from other state living organ donor protection legislation. I didn't bring it up during the budget session, even though I was given the option, because I wanted to have all you smart guys and gals within the room today to have the opportunity during the interim to hear the bill and to make it the best bill possible for the upcoming session in 2023. As I mentioned to a few of the insurance folks in the room today during a phone call on Tuesday, that I'm not an insurance whiz, and this is definitely outside my lanes of expertise. But I hope, as I think this bill does, will greatly increase the pool of possible organ donors for that huge and growing list of folks that are in need of an organ transplant. Ann is here to give her real story of being on a donor waiting list and to answer any questions you may have. I've asked your LSO staff to include the bill in the packet sent to you. Would you like me to go through it now, hitting the high points, or line by line?
If you would just please, if not everyone may have had a chance to really contemplate it. So if you could kind of give us the 30,000 foot, and then if there are questions about specifics, that would be, I think, we'll start with that.
Okay, Madam Chair. An act, organ donor protection. A bill, House Bill 120, an act relating to the insurance code prohibiting discrimination for living organ donors by certain insurers, providing definition, specifying applicability, and providing for the date. Wyoming State Statute 2620-803 is created to read: no individual or group health insurance policy issued by any health insurance issuer or life insurance policy, disability insurance policy, or long-term care insurance policy shall, and there's 4 main things: deny or cancel coverage, deny eligibility or continued eligibility, reduce or limit your coverage or benefits, increase your premiums, or otherwise adversely affect the coverage or cost for the covered person's policy, and without any additional actual risk involved. And number 4, preclude a covered person from donating all or part of an organ or tissue. So this all deals with living donors, not the atomical gifts that was mentioned in your memo. On page 3, the definitions from 2620-801, the covered person has been added, also includes a policyholder, subscriber, enrollee, member, or individual covered by a life insurance, disability insurance, or long-term care insurance policy. I think those have been added. Long-term care insurance policies is one that I am now getting involved in, because I'm getting up there and some insurance people are saying you might be looking at doing this. And Romanet 3 on page 3 on line 14, living organ donor means a person who is not deceased and who has donated all or part of one or more of the person's own organs or tissues to another person for transplant. As they mentioned, the insurance people, you go through different tests, and Ann will be able to expound on that. If I'm healthy and I match 3 or 4 of the 6 different levels, I can donate an organ to a loved one or anyone. And that's what Romanet 3 talks about. Section 3 Act applies to any insurance contract or policy offered, issued, renewed, delivered, or issued for delivery in this state on or after, and I'll change that to July 1, 2023, and it'll become effective. We were here for the last 2 hours. There is no fiscal responsibility for the state at all, so it won't cost you anything. Are there any questions of me, or would you like to hear from a organ donor
recipient.
Well, let's see if there's any questions for Representative O'Hearn first. Representative Stivar? Oh, Representative Ottman. Oh, okay.
Madam Chairman, Representative O'Hearn, how are you?
Good.
What I was wondering was, with the insurance companies, because this is to address this, does this help them then be able to differentiate and be clear on coverage? Are they for it, against it? Did they have any thoughts about it? Could you, thank you.
Madam
Representative
Chairman,
O'Hearn.
Representative Ottman, from what I was talking to the insurance companies on Tuesday about, and I think I heard it today, you can get different policies and you can opt to have a living donor organ portion put into your health insurance. But like Ann will mention, your insurance company is not paying for this. The person that's receiving the organ, their insurance company is going to pay for all of that. Does that answer your question?
So, well, and I think we have insurance companies to testify later, but
Yeah.
I mean, it sounds to me like there are two separate issues here. This bill doesn't speak to coverage by the recipient's insurance of a donor's expenses. This bill, as I understood it, prevents an insurer from saying, I'm not going to cover you because in the past you donated your kidney or something. Those are separate things. So this is the insurance coverage of a donor not at the time of the organ donation, but their life afterwards. Are they looking at the person saying, well, you only have one kidney, so you're not as healthy, we don't want to cover you. I think that's where we're going. But we do
Yes.
have insurance companies here, will testify afterwards. Representative Stivar. Okay, any more, Representative Connolly?
Thank you, Madam Chair. And I'm not sure if this is a question for you, Representative O'Hearn, or for the Blue Cross Blue Shield or other insurance folks here. I'm curious about the word solely that gets used in Romanettes 1, 2, and 3. And so Chairman Wilson just said, the purpose of the bill is to say that, well, you're not going to get insurance, or is to prohibit you're not going to get insurance because you gave a kidney 2 years ago. I'm curious about the word solely. What happens if someone donates a kidney, and I don't know what happens when you donate a kidney, but your blood pressure goes up 20%, for example. That's not, blood pressure increases can be because of a zillion different things, and health insurance companies can choose what to do because of that. So what happens when there's tertiary effects to the donor of donation that have healthcare implications? I know, for example, you're not supposed to drink after you give up part of your liver, for example. So I am curious about the use of the term solely, and if that term is necessary, because it seems limiting, honestly, to me.
Representative O'Hearn?
Thank you, Madam Chairman.
Just helping you
Representative
practice
Connolly.
for January.
Yes. We'll find out what happens next Wednesday if I will be there in January, as will some of us. I'm no insurance whiz, so maybe that would be a question for back there. But it sounds like if I choose my health insurance and I'm paying my health insurance premium every month, and I have chosen, I may at some point make a living donor organ. I might donate an organ in the future. My insurance premiums, I assume, might be a little bit higher from what she was mentioning on the thing. And they may be able to come back and say, well, yeah, you've been paying X number of dollars for the last 21 years, and now you're going to give a organ. And you know what? It's, even though I'm in good health, and I met all 6 of the requirements for showing that I've got 2 kidneys and I can give one up. And financially, it costs less money to have a person on a donor list than to be on the dialysis machine. So I guess if I'm circling around here, solely
if I say I want to be a organ donor while I'm alive, I will pay for that price now. That answer your question?
Well, I was just going to say that that's a good hypothesis, but I'm not sure that many of us have that many options when we get our insurance
Okay.
in packet from our employer. But let's hold off, and we can circle back, and we'll hear from the insurers, and we can quiz them later. I think we're still in the information gathering stage. More questions? Don't forget, we have the witness here, and we've got insurers, we've got a lot of people, but any questions specific to the bill for Representative Stiver, or for, sorry, Representative Ahern? Okay, ma'am, welcome, and if you would like to tell us about your experience, because I gather that's what brought Representative Ahern to us.
Good morning. Yeah, I'm Ann Bina. I live here in Casper. I wanted to share my journey with you, my kidney journey, because I think it'll relate back to why this Living Donor Protection Act is so vital and so important to all of us that need a kidney transplant or a liver transplant too, for that matter. My journey is a little bit different than a lot of people because I'm not diabetic. I didn't have high blood pressure, no autoimmune disease, nothing that you would think all of a sudden I'd be in kidney failure. Actually, it was something so simple. When I was 9 years old, I had strep throat. And strep throat, you get better, everything's fine. Well, about 2 to 3 months after my strep throat, I wound up in the hospital with nephritis, which is like an inflammation in your kidneys. And I was in the hospital for a while, and the doctor told my parents that I would have a reoccurrence of that later in life. And, we got on with life. I was active in sports in high school, went on to college. By the way, I was a Wisconsin girl, so I went, born and raised in Wisconsin. So I went to the University of Wisconsin, met my husband. He was an ROTC. And so when we graduated, we married, and off we went with the Air Force. For 25 years, he was here, there, almost any state you want to talk about, we were there, in South Korea, Germany. When we were in Whiteman Air Force Base, Missouri, I had just gotten my master's degree, and so I was going to work, and I used to get really bad migraine headaches. And so I was in seeing a doctor on my way to work, getting medication to prevent the headaches and everything. And my, how they do your blood pressure, pulse, all that. And my blood pressure was really high. And I said, well, I'm in a hurry to go to work. And so they had me come back the next day. And of course, it was just as high. So now they got worried, and they started doing a bunch of testing, and they discovered my kidney function was at 50%. And so just like here, they'd probably send you down to University of Colorado for more testing. I was sent to the University of Missouri in Columbia, to the University Hospital, to have some testing done. They did, because I was healthy otherwise, nothing was wrong. So they did a renal arteriogram, see if there was a blockage, because you could fix that. Well, that was fine. And so they did a kidney biopsy. And when they ultrasounded my kidneys, they did the healthier looking kidney. And they found that I had FSGS, focal segmental glomerulosclerosis. It's a real mouthful. Basically meant my kidneys were getting all scarred up inside. And so it was going to be a slow progressive disease, and that I would need a transplant in the end. This was 1992. In 1998, my husband had retired from the Air Force. We were living in the Milwaukee area, and I was put on the transplant list. We had graduated from University of Wisconsin in Madison, and that's where I got put on the list. I was also double listed. I was also listed in Milwaukee. That was 98. By August of 99, I needed dialysis. I started dialysis in October of 99. I got the call. There was a kidney for me. University of Wisconsin was calling.
and said it was a 16-year-old boy that had been killed in a car accident. It was a 4 out of a 6 match. You know, they always look at tissue for a kidney, and they want to match as much of it because it would prevent rejection of that organ. So it was a 4 out of a 6 match. And I still remember being in disbelief. First of all, I really need a transplant. And then like, I have to get there now. You know, it's like 2:30 in the morning, they call you. Why is it always in the middle of the night? I don't know, but it was 2:30 in the morning and I had to be there by 5:30. It was a 90-minute drive. They were going to take me right away into surgery. And of course, when we got there, it was 3 o'clock in the afternoon by the time they finally had me into surgery. My kidneys started working immediately, just like you see in the movies. It started making urine immediately. And they had me back to my room, and I was in more pain than I can even express to you. I was in the hospital a week. I started walking right away, exercising as much as I could, and I take more pills than I can even tell you. Immunosuppressant meds so I don't reject my organ. And of course, in the beginning, you know, you're on antibiotics, fungal antibiotics, bacterial, viral, because your immune system is so suppressed that you are really in danger of getting sick. I cannot even put down words what a kidney transplant means to me. You know, in the transplant community, we say it's a gift of life. And that's exactly what it is. I have my life back. I saw my daughters graduate from college. I saw them both marry. I now have little buddies. I have grandsons, and I'm able to be a part of their life. I've been able to travel. My husband and I have been to Europe. We go down to the Caribbean, we go to Mexico. I don't have to worry about anything but making sure I take my pills every day. And because I think I'm so outspoken about what this means to me. I'm also, when we were in Wisconsin, I was part of the Wisconsin Donor Network. Here I'm in part of the Wyoming Donor Alliance. I joined the National Kidney Foundation. I am a kidney advocate for the state of Wyoming. I am also a peer mentor. I call people that are been there, done that kind of thing. People that are on the waiting list right now, and they have questions, they have concerns, they have worries. And so I try to help them because of, just from my own experience. I'm not a medical expert or anything like that, but I do it from my own experience.
So that's a wonderful story, and I hope your grandsons are good Packer fans. But let's just bring it tightly, a little more tightly into the issue, because what we're trying to do with this bill is protect the donors. So if you have experience with what the donor problem is.
Yeah, the donor problem is this. When somebody wants to be a living donor, I had personal experience with this because I had a friend from the Air Force days who was going to be my donor. And, you know, first they do your blood type and make sure that you're a match. And then you, as a donor, have to go through a lot of tests to make sure that you are healthy enough to give a kidney. She did that, she had done that, and then she found out that she was going to be discriminated against for her job. She was in danger if she was going to be out of work for longer than 2 weeks, that she was going to literally lose her job. And so she was contemplating doing this because of that. I know someone else, I have a cousin who was going to be my match, and he was at the age where he didn't have life insurance yet, but he was going to get life insurance, and he looked into it, and he was going to be discriminated against because of just having one kidney. Even though he was healthy, all the tests showed that, he would be able to give a kidney. And I think part of this whole bill is the discrimination against the donor, but also because the people on a waiting list now it's almost astronomical. When I was on the waiting list, there were 65,000 waiting in the country. Now it's over 100,000. Just here in Wyoming, there's almost 7,000 people that have chronic kidney disease. Now, not all of them are going to need a transplant eventually, but and the numbers of deceased organs is not enough to handle this. I mean, the National Kidney Foundation says there's 70 million people in the United States that have chronic kidney disease. And the scary statistic is 90% of them don't even know they have it. So by the time they know they have chronic kidney disease, they're probably already at stage 3, stage 4. When you get to stage 5, you're in end-stage renal disease. So I think part of the National Kidney Foundation idea of this bill is, yes, to protect the donor, but to get more living donors so people are not dying. There's like 20 people that die every day in the United States waiting to have a kidney transplant. Last year, 9 people died in Wyoming. I think you can only imagine the numbers that are going to go up as more time goes by, how many more people are going to need to have a transplant. And the living donor is a way to help people get a transplant.
Okay, so to summarize, and then we'll take it to see if there's committee has questions. The essence of this, the bill, this particular bill draft, will have other topics along the same with the word organ donor in them, but this particular issue is to consider whether, as a committee, we want to sponsor a bill that will protect donors of any kind of organ from being discriminated against by their health insurance or life insurance or long-term care insurance after having made an organ donation. And then the effect of that would be not only to protect the donors, but hopefully to enhance the donor pool. Is that an accurate summary?
That's pretty much it. It's
Okay.
also regarding FMLA that,
Well, the bill doesn't touch on FMLA. It doesn't have any, this is only for insurers. So, okay, any questions for Ms. Bina? None presently.
can I make another comment?
Okay.
This morning I found out that there are now 29 states that have passed the Living Donor Protection Act. So we're hoping that Wyoming would join in this.
Very good, thank you. Okay, any, Representative O'Hearn, any more comments before I open it up to public comment? Okay, we've got insurers, we got other folks, anybody else? Representative O'Hearn, if you want to swap over to the left or somewhere so that you can sit, you can stay up there, Representative Hearn, just let them group together on their mic. Good morning. I hope it's still morning. If you can, you'll introduce yourself for the committee, please.
Good morning, Madam Chairman, members of the committee. My name is Heather Roday, and I'm representing Blue Cross Blue Shield of Wyoming, and I have with me Raymond Red, who will be speaking as well. Wanted to thank everyone for their good discussion on this particular issue this morning. Wanted to make sure that when we talk about Blue Cross Blue Shield, we're just talking about the health insurance aspects of this bill. So the bill covers, mentions other things such as life and long-term care and disability and Rocky's going to talk a little bit about the disability impacts of that. But wanted to clarify, I know that there were some questions earlier about this. So health plans, which are included under the ACA, and the Department of Insurance mentioned this earlier, are not allowed to deny coverage or increase rates based on an individual's health status. So Representative Connolly, you were talking about the word solely, right? So health status is everything, right? So a person who, all of the conditions that they may have, not just having been a living donor, we aren't allowed to discriminate against anyway, right? So then we do cover living organs, just like we do for other pre-existing conditions, and that's, I think, what I basically just said. And we believe that the existing federal law that govern our work as health insurers is sufficient to ensure that the living organ donors receive health insurance coverage. But I think Rocky's going to talk a little bit about some questions that we might have that we're happy to work with the sponsors in the future to resolve. So,
Okay, Mr. Red.
Madam Chairman, members of the committee, I think I just wanted to mention a couple things about the bill. And what we've done in our review, we haven't had a lot of time, and certainly we have had discussions with Representative O'Hearn, and we're going to continue to do so. But what I noticed in the bill is a reference to disability insurance, which is something that we might need to talk about a little bit more, because disability insurance in the state of Wyoming really does encompass health insurance. And in looking at the definition of disability insurance doesn't cover certain accepted benefits now. If you read the definition of it, any statute passed after 2011, there's certain accepted benefits that it wouldn't cover. Another thing that I noticed in my review is that there is a federal bill that is being proposed to be passed. And in the states as well, most of the bills, not all of them, but most of them cover life, disability, and long-term care insurance. But in the state of Wyoming, disability insurance really is health insurance, but it wouldn't actually be what would be defined as disability insurance in other contexts. If you look at the federal legislation, disability insurance is defined as the type of insurance that you would get and you were disabled, and then you would be paid because you were no longer able to receive an income. But in the state of Wyoming, disability insurance doesn't cover that type of insurance. So it's exempted from disability insurance. So I think the intent of this, like the good folks have talked about, is to avoid discriminating against people who want to get disability insurance or long-term care insurance or life insurance. And as Heather mentioned, we can't do that anyway. But if the intent of this is to make sure that people aren't discriminated if they want to get disability income insurance or life insurance or that kind of thing, this might not actually cover that. And that would be probably a little bit problematic, because even if we were to delete the health insurance section, because it says disability insurance, it would actually cover us anyway. But in the context of other states, when you use the term disability insurance, you're not talking about health insurance, you're talking about disability income insurance. And I think most states, that's what they're trying to capture, as opposed to health insurance, because health insurance, really, you're not allowed to discriminate anyway. So we can talk more about it. We can work more with Representative O'Hearn, but I just wanted to kind of mention that as a clarification.
Very good. Questions for Mr. Red? Representative Connolly.
Thank you, Madam Chair. I'm kind of looking up and I'm curious about the federal law, which uses the word solely in it too. So I have less heartburn about that. But the federal law, or the federal bill, looks to me like it has kind of stalled for the past 12, 14 months. And so I'm curious about the status of it. And then the second question would be, is there a need for a state law? And is the state law very different? Doesn't look like it too much to me, but I'd be curious more about kind of the federal law and what's going on with it to the extent that you know.
Mr. Red?
Thank you. Madam Chairman, Representative Connolly. I actually don't know why the bill has stalled. I'm not sure if there's just continued discussion. There's a lot of legislation, regulations being passed right now, so maybe it's not at the top of the list, would be my guess. When you're asking whether or not the legislation is important or should be passed, I think in representing a health insurance company, it's hard for me to opine on that particular matter. When it comes to health insurance, I'm not so sure that it is important because as you can see, it's not iterated in the federal bill. And while some states do have health insurance explicitly put into their state legislation, I think maybe this legislation is mirrored off of Colorado. I have noticed, and I would like to be able to say, I can't say with 100% certainty, that most of the state statutes do not include health insurance. It's just life, disability, which is not the same kind of disability insurance as we talk about in Wyoming, and long-term care insurance. So it would probably be our recommendation, and we can talk about it more, to remove the health insurance piece of it. But that's only because we don't want to create confusion with it being in there, because we already feel like we can't do that anyway. So.
Do you happen to know, before I ask the insurance department, does Wyoming have a different statutory phrase for the disability income insurance category?
That's a really good question. I've actually was looking at it over the last week.
I'll be glad to ask the Department of Insurance if you're not, if you don't.
Yeah,
I mean,
sure.
you don't, maybe don't want to speak for them.
Yeah, no, sorry, Madam Chairman. Well, one thing I was going to mention was that I did notice some case law which referenced disability insurance in the context of disability income insurance, but that case law was prior to 2011. So I do think that the disability insurance statutes do apply to disability income insurance, but not to statutes that are passed after 2011. So that's the reason for the change there. So it still applies to those types of insurances, but not for statutes that are passed after 2011. So for this one, because it doesn't use the term specifically, it might not apply.
Department of Insurance, welcome back. I told you that you'd probably need to come back again. Is there a statutory phrase in Wyoming for the disability income insurance that is a separate category or a subset?
Madam Chair, interestingly enough, Mr. Red is correct in the statute he read, and the statute he read does say for any statute with the effective date on or after July 2nd, 2011, and expressly specifically provided by statute, the disability insurance does not include, and then he did go through the exclusions. However, there have been no insurance statutes passed after July 2nd, 2011. So at this time, any health insurance, disability insurance, accident only, dental, vision, it's all considered disability insurance at this time. So everybody actually does apply to disability insurance, including the health insurance.
So if we were to draft a bill that, and we can hear back from Representative Ahern, that was specifically covering the disability insurance category rather than the health insurance that is excluded from the problem by ACA, do we then actually need to kind of open up our disability insurance statutes in general to carve out a particular type of insurance for disability income? I've stumped them. They're
You've stumped
thinking.
the panel. You've stumped the panel. Hold, please. Do we need to open it back up?
Is she thinking, or I'm not
We're
quite.
having a discussion. Sorry, introduce yourself.
Madam Chairman, this is Becky McFarland. I'm the staff attorney for the Department of Insurance. I am struggling somewhat, obviously, with regard to how to address your question. Do we need to open up the statutes, all of the statutes, to address the disability income question? Not necessarily. And part of the issue
is that under 265103 that we've been discussing, it says, and unless expressly specifically provided by statute. And so to the extent that the committee or the proposed bill is actually adopted, if there is specific wording in the statute itself to include it under the disability insurance, I think the issue could be addressed that way.
So I'm not quite sure I grasp that, having not really looked at the whole category. In this, if this bill were to go forward, would it be advisable, to avoid confusion, to put in a definition saying that for the purposes of this act, supposing it were, we might need to recall it an act or something, disability insurance refers to disability income insurance? I mean, it seems like we need to tighten that up.
And there may need to be, Madam Chairman, I apologize. There may need to be a distinction between disability income, which in other contexts and other states is referred to as health insurance, and the disability income insurance, because they truly are two different things. The disability insurance under our definitions is health insurance, and to the extent that it is disability as health insurance that is being addressed in this proposed bill, there may need to be a distinction between the two different types of insurance.
Well, because what I understood them saying, or at least from Blue Cross Blue Shield, is that I think that we wouldn't actually want this bill to address health insurance because that is elsewhere addressed by federal law, and it would just, I think, conflict or add confusion. I mean, maybe, and perhaps, although we can circle back to Representative O'Hearn, maybe he's actually wanting to cover health insurance. But if we don't want it to affect health insurance so as to not conflict, then it seems to me we need to refine the language. And we don't have a current category for that in Wyoming, is that right?
Madam Chairman, that is my understanding. There is a difference with regard to the terminology that is used in Wyoming versus in other statutes, both federally and other states.
Representative O'Hearn, I'm going to just circle back to you on this. So in your discussion with whomever, as you were drafting this and interested parties, did the situation of the federal prohibition of discrimination in health insurance come up? And so are you attempting to say duplicate or pile on to the federal statute, or are you really only looking at life insurance, disability income insurance, and long-term care insurance?
Madam Chairman, I preface this with, I didn't know too much about the insurance industry.
You know more
and
now.
I mentioned this to Heather and Rocky the other night. I thought this was going to be the easy button that I would be able to push. I don't want to make this too complicated. I just want to make it to where I guess Wyoming isn't in conjunction with 29 other states and how we do with disability and health insurance. If this is and that's exactly why I didn't want this to come up at the budget session. I wanted this to be an interim discussion to where all the smart guys and gals I would love to have this, I would love to meet with everybody, and I will work this as hard as it needs to be worked to make sure it meets everybody's requirements and it doesn't turn Wyoming into I want to make this right. So, and I want to make it to where the pool for those needing a kidney or a liver or any organ is larger so that the state saves money and the people get back to their regular lives. Representative Connolly, I think, had a question.
I'll call on people.
I'm sorry.
Representative O'Hearn. Representative Connolly, did you have a question?
Thank you, Madam Chair. And kind of just a clarification. So the bill that I brought up hasn't passed.
The federal bill.
The federal bill. And so that is one that stalled about a year ago. But when I'm looking at it more carefully, it doesn't include health insurance. It includes life insurance, disability insurance, or long-term care insurance. And so that, I think, goes to the Blue Cross Blue Shield folks' point that we don't need or probably shouldn't have health insurance in here because it could cause some confusion because it already is covered elsewhere. However, these other 3 insurance policies aren't, and that's why states are, and the feds are looking at increasing the prohibition on discrimination to these other kinds of policies. So just to be clear, I did kind of look that up, because to me, health insurance was the biggest. And here we have Blue Cross Blue Shield coming up and saying, you don't need to worry about that. And in fact, the federal bill doesn't include it either, because I do think it's already taken care of elsewhere. So going along with your point, Madam Chair, that it might make sense that we get rid of that clause just because it could cause some confusion, even though I thought it was the most important. Okay. Thank you, Madam Chair.
Okay, we're still sort of on testimony from Blue Cross Blue Shield. So just to circle back on the end, any more questions for the folks from Blue Cross Blue Shield? Okay. Is there any other, is there any public testimony on this bill?
This one, this, yeah, it'll stay in life.
Okay,
insurance, disability.
Committee, this is my thought, and you can give some thoughts back. I'm brainstorming right now. I think we have a couple of possibilities. I think we could say as a committee that we want to work this issue more, but it needs, I think, not just, I think we might need to do a little bit more looking. I'd be a little bit leery of amending it on the fly right now before we've looked a little further at the statute. And so that would be one option. So, and I guess what I will is I'll survey the group. I think we could say we want to take it on, and we need to work it some more, and have something maybe for October. The second possibility is that we could just say that Representative O'Hearn has benefited from our sage advice, and he can go back and do the same thing for himself for the next session. And lest you be concerned about where you'll be next week, half of the House committee, it won't be here in January either. So I'm not sure there's a real advantage to that. But so I'm just going to go down the line and ask if you'd rather have a committee bill or you'd rather let Representative O'Hearn work on it more. I think those are basically 2 options. So Representative Stivar, what do you think? Okay, wait, I'm just writing down O'Hearn or Labor. Okay, Representative Ottman. Okay, Representative Hallinan.
I say let Representative O'Hearn.
Okay, Senator Furphy. Oh, here he's there. Senator Baldwin.
I hate to break the trend. I think Representative O'Hearn, but I think he needs to commit himself to meeting with the insurance and with the people to get this definition clear, because that's really the key to the whole thing.
30 minutes.
Representative Connolly.
Committee.
Committee, okay. Senator McCune.
Let's give it back to him.
Back at you. Okay. Senator Wasserberger, welcome to the Labor Committee.
Well, thank you, Madam Chair, but as a proverbial late
You're allowed to speak. That's not, no, this is Wyoming. You have to vote aye or nay. We don't say present. Well, I don't want to not ask everybody. Senator Hutchings, what is your thoughts?
I believe O'Hearn should carry this bill in the House as a personal bill.
And Representative Flitner.
Madam Chairman, it's a toss-up for me. I think it would benefit the bill itself. It would benefit passage if it were a committee bill, but like you said, who knows, we'll be here in January, so.
Representative O'Hearn, I think the message is clear. However, I hope that this time, I think it's been to our benefit, certainly, and those of the committee who come back will be, probably the bill will come through the Labor Committee, and you've already pre-informed folks. You have had a chance to hear more. So the specific issue is, I think what you probably need to do, and you can just chat again, is on page 1, delete, on line 13, delete the words health insurance issuer. And then on line 14, after disability, insert the word income, perhaps. I don't know that we have defined that in statute. You might check and see if that is, if there's a definition of disability income. And then, and I don't know, the definitions on page 3, I'm not sure where they sit, so, but I think that's probably what you need to do. And it sounds like with that work done, I think you have a way forward.
Okay. Thank you, Madam Chair. Thank you, committee.
Thanks very much. Go Pack. I'm sorry.
Yeah, I want to thank
I'm from
everybody
Pat,
too for
Wisconsin, so-
taking this, this on. And hopefully it'll, there are so many people out there that want to be living donors. And hopefully this will not have any, anything that will prevent them from doing this.
I think there will be support for the
Yeah.
project. We just
Yeah.
need to tighten it up a little bit. Okay,
Thank
committee,
you.
we have, thank you very much. We have, actually now, want to hear from the funeral practitioners on a issue of decedent organ donors. You know, some of us have worked in healthcare, so talking about decedent organs before lunch doesn't bother some of us. I'm okay with it. Are we going to have graphic photos or no?
There we go.
Welcome, just introduce
you.
yourself for, let's see, I mean, let's just check. Do we have,
Yes, you
Uh,
have Jeff Jacoby online, I hope.
oh, that's excellent. And I'm just, do we have?
Critically important.
Let's see, is the pertinent paperwork done? I see we've got a memo, subject burial transit permit. Is that this
Yes.
topic? Is there any
Yes.
other handout that's this topic? They kind of merge. No, that's pretty much it. Okay, all right, welcome. Just introduce
Thank you,
yourself
Madam
if
Chairman. I'm Lori Oberkeit, and we are representing the Wyoming Funeral Directors Association today. I'm here to just kind of try and wrap things up, but most importantly, to introduce you to online Mr. Jeff Jacoby, who is a funeral practitioner in Cheyenne, and he will go through the meat and the totality of this subject, and I'll let him take it away.
Okay, and Mr. Jacoby, welcome. I also hear that you've had a loss in your family. Do I hear your mother, was it?
Well, aren't you kind, Madam Chairman?
We're very sorry to hear about that, and thanks for being here in the midst of that troubles.
Well,
ahead.
she was a lovely human, and it was a sudden onset of pancreatic cancer, and it was an awful experience and a beautiful experience, and I'm sure many other folks have been through that. And as a funeral director, it's very different, obviously, seeing someone you love personally die in front of you through hospice, but they were wonderful. And regardless, I thank you for all the kind words. And so thank you. That means a lot.
Absolutely. Okay, tell us what we need to know.
Well, I'll try to keep my comments brief because I know that you have many other things on your docket. So in regards to the issue in regards to donation and donor alliance and transportation of human remains across state lines, that's really the focus of my comments today. I just want to kind of reiterate what we discussed earlier this spring in regards to the concerns that I have as a funeral professional and someone that owns funeral homes in Cheyenne, Casper, and Rawlins in transporting human remains across state lines. The issue is not with donor alliance. So I just want to make that perfectly clear. Listening to the testimony earlier in regards to anatomical donation and also the importance to families to have their loved ones play a role in basically giving life to individuals that need that care is not the issue here at all. You know, we provide support to Donor Alliance consistently throughout the state and of course from my 3 funeral homes. The issue is about what happens to those remains following the transportation and after the donation process. That's the issue. And I'll give you an example. It was not that long ago that we received a phone call where the death occurred at the hospital,
We then receive a phone call from the hospital stating that we use John Doe had passed away and Donor Alliance was going to be transporting for donation purposes. Fine. We provided a temporary, well, it's not a temporary permit. That's not true. A permit allowing that individual to be transported. The individual was transported from the hospital directly. I never took physical custody of the remains. Transported down to Donor Alliance for donation. They did their part, which is fine. And then the next thing we know, we're getting a call from a cremation service in Colorado that the individual's family would like to use them for the cremation process. As I mentioned to you in the spring, there's been instances of this where I'm not even familiar with the name of the discount cremation service. They are not in a state in which funeral service is regulated. We talked a little bit about the concerns associated with that. It's not like Wyoming, where you have a state board that makes sure that certain rules are followed. And so we have been told by Vital Records that as a deputy registrar, which I am here in Cheyenne, and I am obligated to issue that permit to allow for those human remains to be transported across state lines for donation, which I'm happy to do to support the family. But then in that instance, the family had requested the discount cremation service, which is a whole nother issue, which is fine, but I never even physically saw that human being. And now I'm issuing a new permit for purposes of cremation. I believe that this process is not by Donor Alliance. I think that this process is wrought with concern and potential for problems relating to possibly parting of human remains down the road, getting in the wrong hands of an unregulated facility. I'm not saying that particular facility would do that. I'm not suggesting that, but I think that there are concerns when those remains are not being returned to the state of Wyoming, where there's no chain of custody whatsoever. We have been told that we are obligated to issue that permit, or the convenience of a funeral service practitioner will be removed from my ability to do so, making it, because it is very convenient for me to issue permits for the families we're serving, whether it's anatomical donation, meaning whole body donation, meaning cremation, meaning burial. It doesn't matter what the disposition is. But my concern is that those human remains have left the state. I have no idea who these folks are that the remains are going to. I know the family has selected them. I understand that. They're not being brought back to the state of Wyoming. I am forced, in a sense, to issue a final permit for burial or cremation. And then from there, I have no idea where those remains are going. I'm sure you are familiar with the example that was given to you by that handout in regards to the funeral home in Montrose, Colorado, that was parting human remains and selling body parts. There is no oversight in the state of Colorado for this until something like this gets totally out of hand. It gives us a black eye within the industry. It makes it look as though we're trying to financially benefit from the hardships that families are going through. But more importantly to that is the fact that you have a chain of custody issue in regards to the coroner. I'm going to give you an example that happened just recently, within the last week and a half. The coroner transported human remains to Greeley for examination. We get a call from a crematory in Greeley asking us to provide them a cremation permit. I didn't even know that this human passed away. The coroner refused to do anything with the discount cremation service in Greeley, told them that they would be, meaning the deceased would be transported back to Cheyenne, and you can get a hold of a local funeral home and they will assist you from there. They called us, we took care of the initial preparation, we embalmed, and then we issued a permit for purposes of cremation following the viewing in Colorado. That was the family's choice. We honored it, of course, but the coroner required that that individual be returned. I can tell you that that is not exactly what was preferred in a discussion that I had with Vital Records and that particular coroner. It was probably about, 8 to 12 months ago. I don't remember exactly when it was. And she has put her foot down and said, I will not release human remains in the state of Colorado following an examination they will be returned to the state of Wyoming. The problem is, for the coroner situation, it's a very difficult position for her to be in because one, she's been told that she has to, but she's refused to, until, of course, the person is returned. And they go through what has been the traditional channels of working with the local funeral home to issue that final permit and to assist that out-of-state funeral home. Well, what happens in the instance where an individual dies at the hospital? The cause of death is believed to be natural. Donor Alliance comes, takes possession with the help of a local deputy registrar, such as myself, transports across state lines, does the donation, and then come to find out the individual had a fall, for instance. There's an accident involved. And in that instance, it becomes a coroner's matter. The human being is down in Colorado. The evidence has been tampered with. And now I've issued a permit for the individual to be transported to a cremation service in Casper. The family follows through with their wishes, and the person's been cremated, and the coroner never even sees the human being. So my belief is that we change the statute, not allowing just a random person to issue, as allowed by Vital Records, an organization. There was a discussion that if we didn't do what we were asked to do, that there would even be a consideration that Donor Alliance would be given the authority to issue their own permits. Can you imagine? Human remains are leaving the state without anyone really knowing about it other than Donor Alliance and the hospital. And of course, the state finding out the following day after the permit's been issued at 2 a.m, for instance, because there's a period of time that individual needs to be transported, have been placed in refrigeration timely, which we help families with, of course. So my belief is that a funeral service practitioner should be the one that issues these permits as a deputy registrar, that it is a temporary permit for purposes only of donation, and the individual needs to be returned to the state, that physical custody needs to be taken by the funeral home or the funeral service practitioner before the permit's issued. And that's really helpful in the city of Cheyenne because we have refrigeration. The individual's not lying there in a hospital bed waiting for Donor Alliance to get there. And then when that individual is returned, then we will work with the family or another funeral home to assist, whether it's Colorado, whether it's Wyoming, it doesn't matter, my competitor, whatever, it doesn't matter at that point. The point is we're doing what the family wants us to do. And then we will issue what I would consider a final permit. The other temporary permit that should be created is by the coroner. Coroner should have the right to create a temporary permit, what I call a temporary permit for purposes of examination to leave the state. There's a whole nother discussion whether or not the examination should be done in the state of Wyoming. That's for another day, another time. But to leave the state to go to Colorado for the examination and then be returned back to the coroner's office in their care. And then it will be up to the deputy registrar, the local registrar of that county to issue that permit. There are funeral homes that will specifically not issue a permit unless they take physical custody. And I know of one, and he doesn't live that far from me here. We have tried to work and do the best that we possibly can to help the families in our area to do what they want and to support Donor Alliance. I would just caution you to be aware that there is potential concern down the road with parting of remains, mishandling of remains. It can happen here in the state of Wyoming. I understand that, but you have a board that oversees that. You have funeral professionals that are responsible for their licensing to someone. In the state of Colorado, it is to no one. And then as a business owner, I have a concern that I'm releasing human remains unseen to go to the state of Colorado that can possibly end up in a situation where there's concerns like Montrose, Colorado, and you can't tell me that I'm not going to be legally responsible down the road for that. I can assure you that Jeff Jacoby will be a party to whatever happens because I'm the one as a deputy registrar that issued and allowed that remains to leave the state sight unseen, even though I got a call and had custody, right? So I would encourage that the language and the recommended statute be considered, and I understand it needs to be tweaked. I'm sure we just put it together and did the best that we can, but be adopted in order to not only encourage donation, very important, We want to be there, but also to protect the interests of families of that loved one, to make sure they're returned to the state, and then we have a better understanding as to who we are releasing those remains to. I'll be glad to answer any questions that you might have. Thank you, Madam
Questions
Chair.
from Mr. Jacoby? Representative Connolly.
Yeah, thank you, Madam Chair. Mr. Jacoby, I'm looking at the memo that you put together July 28th, 2022, and on that second page, the second bullet point is one of your suggested changes, which is that the phrase "person acting as such" is too broad and that it should be limited to funeral practitioner. So I'm curious, you would take away the abilities right now of coroners, Indian tribes, and the Donor Alliance, for example, to move bodies or decedents in the same way that they are now. Have you spoken with representatives from the tribes, from a coroners association, and the Donor Alliance in relation to your suggestion here?
Mr. Jacoby.
Thank you, Senator. It's an excellent question. In relation to the coroner, in the suggested new language, the coroner is given the authority to issue a temporary permit to allow them to transport across state lines. So in reality, it's not limiting their ability to do that right now at all. What it does limit them from doing is releasing it to an out-of-state funeral home without what I would consider a permanent burial or cremation or anatomical donation permit. And so I don't think we're limiting or tying the hands of the coroners at all. Their job is to examine the cause of death and to come to a conclusion. We aren't preventing that from happening at all. In regards to Donor Alliance, that's really the concern that I have greatly. Offering potentially an out-of-state organization that's not regulated by the state of state of Wyoming to somehow have the authority to transport human remains out of the state with really no one knowing in the dead of night other than the hospital or the nursing home that's releasing those remains. And then requiring me as a deputy registrar under the current statute to issue a permit for cremation or burial without having even been notified possibly is a serious concern. In regards to the Indian tribes, I have not had any discussion with them, so I'm going to plead ignorance on that, and that's something probably Jamie Kirkland in Riverton, who is a board member for not only the Wyoming Funeral Directors Association, but also the Funeral Service Practitioners Board. I really think he would be the better person to speak to that. And if he's on or available, that would be great. If not, I'm sure he can provide you something in writing to share his thoughts on that. But lastly, Donor Alliance. I have spoken to Donor Alliance. Donor Alliance has made it perfectly clear to me that they will not be prevented from providing this service. And I assured them that that was not the intent at all. We just want to make sure that there's a clear chain of custody and those remains returned to the state of Wyoming before we issue a final cremation or burial permit. That's all. We work with these human beings all the time. I would say that it was strained at a period of time because they felt that we were trying to interfere with the federal mandate that service be provided. That is not the case at all. In fact, I get up at 2 a.m. and so do my other deputy registrars within the state who are FSPs or funeral service practitioners to help them to refrigerate the remains, to provide assistance with transportation. So I sincerely disagree with that. So I just want you to know I've had constant communication, not only with the previous funeral home liaison with Donor Alliance, but with the current one to let her know that we want to be here. We want to help. We want to help families. We just ask that the remains be returned. That's all. And then we'll work with whomever the family wants us to work with.
Follow-up, Representative Connolly.
Thank you, Madam Chair. Just a follow-up. I am concerned that there's been no discussion with the tribes if you're going to be limiting their ability to in some way move their decedents.
Senator, I apologize. I can't hear you. I am so sorry.
Oh, sorry. I'll bring the mic. Can you hear me now?
I can. Thank you.
Okay. Sorry. So I was just commenting to start with that I do have some concerns that there has been no conversation with the tribes when it appears that the suggested language will limit the ability for them to be kind of behaving in the ways they are right now in terms of the movement of bodies. And forgive me for being blunt here, but it appears to me that what you're suggesting is that licensed funeral practitioners become the gatekeepers. and become the gatekeepers of a whole system right now where you're not the gatekeeper, but that you will become the gatekeeper. And so first, is that true? And you're nodding your head yes, so just to be
No, I'm
clear.
not. No, I don't believe that's true. I'm just nodding to your statement.
Okay.
I think it's a fair
Okay.
question.
All right. So that was the first part, but it does appear to me that you're attempting to become the gatekeeper for the issuance of the ability to transport bodies. And then I am curious if there's a fee associated with that process, and that therefore there will be more incurred costs to whomever because of what looks to me like a new gatekeeping system.
I'm going to piggyback onto Representative Connolly's question, though, before you answer. So it seems to me that you are already the deputy registrar, which you are a paperwork gatekeeper. What you're saying is you're the paperwork gatekeeper without the physical custody of that person. So, and if we just kind of clarify that, but then do you happen to know, it says, I'm looking at, the pages aren't numbered, but the fourth page seems to me to be all of the proposed amended language. So in the second paragraph under A, it says the permit should be issued by a local health registrar or a funeral service practitioner designated as a deputy registrar. Are the tribes currently by rule identified as deputy registrars or the whole health registrar? Do you know, or in what way, do you happen to know in what way they are brought into the permitting process?
Well, I think it's a valid point, and one that I probably can't answer to your satisfaction, to be honest with you, Madam Chairman. I am not familiar with exactly what the Indian tribes have in regards to a policy or procedure placed in regards to issuing their own permits. Again, I think that's something that Jamie Kirkland can answer. I will tell you that this is not intended to limit the tribe's ability to move human remains from one place to another. That is not the intention. Nor is it the intention of me to become the gatekeeper. And I like the term. I'm just smiling at it because I don't see myself that way whatsoever. The reason why I think funeral service practitioners play the most important role as a designated deputy registrar is due to the fact that we understand the statutes fully of funeral service within the state of Wyoming and what's required. I think it would be a concern for the well-being of families and the decedent to have someone who doesn't understand what the rules are when allowing a human remains to leave the state and end up either being buried or cremated in an unregulated industry in another state. So that's the rationale behind that. And I think it's reasonable. I don't think it's unreasonable. It's not intended to control the flow of commerce as a quote gatekeeper. I think it's protecting the interests of the consumer and the family. In regards to the cost issue, the cost is very minimal. First of all, when we issue a permit on behalf of Donor Alliance's request and working with them, the family doesn't pay that. The cost of the permit is actually paid for by Donor Alliance. And that's our quote assistance in providing the permit. It's minimal. It can be established between the funeral home or the funeral service practitioner and Donor Alliance. I can tell you here within my office, if it's during normal business hours, it's $50.
So, Mr. Jacoby, if I can, I think we might need to back up a little bit more on this issue. I have not had any person that I know of lately die in the state of Wyoming, so I'm not aware. Who issues the death certificate? Is that you?
It's a great question because it's the same question that any family would ask when they walk into the arrangement conference room. And so our responsibility within a period of time is to obtain the information for the death certificate and submit that electronically to Vital Records, which then will land in a sense on the desk electronically of the certifying physician that's going to state what the cause of death is. And then from there, it's returned back to the funeral home. We make sure that all the information is correct. And then ultimately, once proved, then it's submitted electronically to the city county health building, which then ultimately results at Vital Records. And that's where we obtain all the original certified copies from. It's a procedure that could take anywhere from 3 to 7 business days, depending upon how quickly we can get the information. But don't forget, we're issuing permits according to statute. And it states that we're to obtain as much information as possible before issuing that permit. There's instances where I have the name of the decedent, the date of death, maybe the date of birth, and where the death occurred. And then that individual is ultimately going to go to Donor Alliance for donation. One can make an argument that we haven't followed through with that properly, but that's all the information I have. And so that's what we do. And not only that, we're obligated to do it. Don't forget.
So right
Records knows
now,
we have to.
I'm just making sure that we pull us through. Right now, under statute, I mean, whether a person is donating organs or not, if a person dies, whether at, well, let's not say at home, because I guess if they were unattended. I mean, I'm trying to do the simplest one. Suppose they die at the hospital and they were under doctor's care, and the hospital calls you and says, you know, Joe Doe has died, and then you gather the information to make now if the person is going to be, if you're going to handle the funeral, you would probably receive the body, you will get the information to prepare the death certificate, and you also issue a permit to bury the person. In this case, you're kind of permitting yourself because you'll do the burial. And I'll just kind of go on. But then, so what you're saying is there are some cases when the person dies at the hospital, let's say, and you are statutorily required to get information from the hospital to make a death certificate, to issue a permit for them to be buried, which might happen somewhere else, and you object to permitting a body to be buried that you haven't actually seen. I mean, I'm simplifying, obviously.
No,
but
I think, Madam Chairman, I appreciate the statement. I think you're spot on for the most part. I'm not objecting issuing a permit per se to try to help a family.
Right. I don't mean object in the sense of that you're getting miffed. I'm just saying that, you know, for a person maybe with a law enforcement background to say, yes, bury this person, a person that you have never seen, either we should take away your requirement to issue permits for decedents that you haven't seen, or have you see the person. I mean,
yes, I will tell you that I do have a concern with that. And there are, like I said previously, there's some funeral professionals in the state that will not issue a permit if they don't physically have custody of those human remains. And I know that there's a concern out there that we're trying to, in a sense, be protected within the, you know, the industry within the state. I would argue against that. I would argue that we have shown consistent attempts to be supportive of the donation process, to make sure that these remains get where they need to be so that the family's wishes are followed through, or even the decedent's wishes are followed through. So in regards to that, yes, I would prefer to have physical custody. I think it's important.
okay, I've been sort of drilling poor Mr. Jacoby. Any questions, more questions for Mr. Jacoby?
Not at all. Not at all.
Representative Ottman.
Madam Chairman, Mr. Jacoby, thank you. And I'm sorry, just a point of clarification. So when there is a person that is deceased, if it's at the hospital, then there is notation or information of where that body goes. And I guess where my question is that in this day of people wanting to know, you know, where the human remains are, that seems to be the question at hand, is that chain. So if a person passes and they have decided to have some organs donated, then they go off to another place. If they don't have family or anything, I mean, who buries them after, what happens to their bodies after they donate a piece or an eyeball or whatever? What happens to the rest of it? And I guess I'm wondering who's responsible to know that, particularly if there isn't family involved.
Yeah,
Mr.
well,
Jacoby.
Senator, I appreciate the question, and it is a concern. It doesn't happen that often. But don't forget, we got to start from the point that Madam Chairman was bringing up, and that is that you have a death at the hospital. You have a request by the family or a request by the decedent to have donation. I'm contacted or notified to assist with the permit. According to vital records, that's not necessarily the fact that the family's chosen me, is that I've been asked to provide that assistance. I'm asking that I take physical custody to do that, make sure that it is who that human is and says that they are. And then I will work with Donor Alliance to get them where they need to be with the understanding that they'll be returned. And then I'll get them, I'll provide a final permit according to the proposed language to wherever they want to. Now, meaning as far as the disposition, Colorado, any other state of Wyoming, my competitor, whatever, doesn't matter to me. At least I know who that human is and I have custody of that human before I issue a final permit. Now, in regards to your question, what happens to those individuals that have no family and donation has taken place? There is a indigent program within the state. There is some additional funding that was provided in support of your folks' committee. Been wonderful, just wonderful in assisting us with all of that to make sure that there's some funds, though they're minimal, funds to take care of those humans. And so we work directly with the county coroner and with his or her budget and making sure that those individuals meet those requirements. And then whatever the county tells us, whether it's going to be a direct burial or a direct cremation, but those cremains here in this county of Cheyenne, Laramie, here in Cheyenne, they will be buried. They will not be released or returned to a family that is, quote, abandoned the remains. Now, you're referring to a situation where there is no family. Unfortunately, it's a quite unfortunate thing that there are families that will abandon their loved ones because they don't want to pay for anything, or there's some issues that the drama that exists. And all families are broken, including mine. So I'm not pointing fingers. I'm just saying that it's an unfortunate thing. And so we help the county in a sense. We help our community by providing, in a sense, a discounted service to provide that service, either bury or cremate that individual. But in the case of cremation, those cremated remains are not returned to anyone. They are actually buried here in the city of Cheyenne, for instance. I don't know if that answers your question, but I appreciate it.
Follow up. Mm-hmm.
And again, this is just a point of clarification. So what I'm understanding and what I've been privy to believe is that at the point of death, there is a medical examiner, police, or someone that verifies the cause of death. So that's all taken care of. So what we're looking at now is that well, let me just ask this. Is it illegal for a person to donate their body to science or to have pieces and parts donated and then not specify what should be happening? I mean, if a facility organization gets a cadaver and they're doing this and this and this, what legally are they supposed to do, or is there nothing legal, and that's what we're determining here?
Okay, Senator, it's a good question because it's confusing. So what I'm referring to is really donation following the death before disposition. And we're talking eye nucleation, we're talking skin, we're talking long bone. There's another topic of donation that's discussed specifically within the proposed arrangement or statute that speaks directly to full body or anatomical donation of the full body that the family signs off on or the individual pre-arranges in advance. We help those folks as well. The main one we work with primarily, there's a couple in Colorado. Main one is Science Care, and we'll talk about a concern with that was in the news not long ago. And the remains is transported with the necessary paperwork with the permit to Science Care, and they have been authorized by the family to basically do whatever they need to do for purposes of scientific research to that human remains. And then following that, then the individual is cremated and returned to the family at no additional charge to them. So we have two donation issues. We have Donor Alliance that takes care of the eyes, primarily skin, bone, and then they're returned back. We request that they're going to be returned back to the state of Wyoming, and then we'll decide, the family will decide where it's going to go from there. Or full body donation. They will have the remains for 6 months, a year, however long, and then they'll cremate themselves and then work directly with the family. We have nothing to do with that remains once we provide a permit for transportation for full body anatomical donation. Science Care is that company that we use primarily. I will just tell you that there was something within the news not long ago with Science Care, and I don't mean to be graphic, that's not the intent, but you need to be aware that it can happen. And that is that they were transporting human remains, heads. I don't know how it happened, but the vehicle was parked somewhere. The driver left, and someone somehow, some way, took possession of those remains. It's a concern. It's a concern for me as a funeral professional with my license on the line, issuing permits for remains going to certain places, that a service is being provided and they're released to an unregulated agency or an unregulated business. And what's going to happen? Are 99% of them good? Probably. You have a handful at the turn? Absolutely. And I just don't want to be told or forced to issue a document allowing something like that to happen and then being in the mix for a family that's been harmed because of something that's not regulated. We just ask that they come back to the state. I have custody. We'll release them to whomever.
Thank you.
More questions? So I think, Ms. Urbicite and Mr. Jacoby, what we're aiming at here is in the packet, and clarify if I'm not correct, because there's a number of pages here in the memo. We've got statutory reference on page 2, then we've got recommendations, and the recommendations, that first part on the third page, I think is existing statute.
Correct.
So the draft you folks would like is on what is not actually numbered, page 4. I'm just going to put a 4 on here so I remember. So, and I haven't parsed it through word for word, but what I'm underlining on page 4 is that we would specify funeral service practitioner, which is the current language. We don't have a funeral director anymore anyway. Or
Correct.
person, we were deleting person acting as such. And because we don't have it in red, it gives exception, and then the last says, then we've inserted in essentially that it will require the dead human body to be returned to the state. And then we have an insertion about what happens to a full body. That seems to be the sort of the short version. What I think I'm maybe getting from, and just so that we know where to go with this committee, and actually first I'm asking Mr. Jacoby and Ms. Urbicite, did I pluck out the salient parts of the proposed amendments?
Madam Chairman, the only thing I would add to that is that you have the final permit and it states for burial, cremation, alkaline hydrolysis, which we don't have currently in the state, but I'm sure it will come at some point, which is basically another form of cremation, but liquid cremation in a sense, and full body donation. Then it provides 2 temporary permits, one that can be issued for purposes of donation, like with Donor Alliance, requiring the remains to be returned, and another allowing the coroner to issue a temporary permit for purposes of examination and being returned to the state. That's primarily the main changes for that, other than you touched on something very important, and it's the term or person acting as such. We were told in that meeting with Vital Records and John and Bridget Radomski and the county coroner here, which is Rebecca Reed, that if we don't follow through with the request of Vital Records, he excuse me, the department has the authority to designate whomever they want to go ahead and issue these permits. And that may include an out-of-state agency like Donor Alliance. I'm stating that that does not make sense for the protection and the well-being of our community and our families. I would be appalled knowing that my loved one left the state, in a sense, to go down for donation without even being identified by the individual that's issuing that permit. So I would say that those are probably the main factors. It doesn't prohibit us from issuing a final permit to a Colorado funeral home or discount cremation service. Is that what the family ultimately wants? It's fine. We will do whatever the family wants. Let's just do it the right way. Let's create a chain of custody, particularly in regards to the coroner and the examination process.
Okay, so committee, and we'll take public testimony and all that, but I think what I'm coalescing here, and this isn't the final, I'm not going to ask for a vote just yet until we hear public testimony, but I think what we're wanting to do is ask LSO to draft, because remember, we still need an actual bill, asking LSO to draft the bill using the language on page 4, and we also need to find between now and October to clarify from the tribal folks what their involvement is, whether they're deputy registrars or not, to make sure that we don't exclude them accidentally, because I don't think that's our intention.
It's not.
And then we can come back in October with this as a draft, with the knowledge about what the tribal position is, and obviously any other amendments that we choose to make in October. That's where I think we're at. But we'll continue, we'll ask Ms. Urbakite if she has any more testimony, and then I'll see if there's any public testimony still on this.
Thank you, Madam
Ms.
Chair.
Urbakite.
I think you boiled it down perfectly. We absolutely did not mean to cause any hardship with the tribes or to leave them out, and I will personally check in with the tribes and find out what's going on next time I'm over spoiling grandchildren. But you really have captured it. That's kind of the basics. The whole concept here is the chain of custody, and we want to narrow that down so that our families know where those bodies are and when the body's going to be returned and how the body's going to be returned. And so this is starting language, and definitely we will work with LSO and with the committee anyway that you request us to kind of tighten it up, but that's, you kind of hit it on the head. That's what we want to do.
Is there any public testimony on the bill? Donna?
Chairman Wilson? Chairman Wilson?
Oh, good. Well, let me call on our committee members. Senator Hutchings, did you have a question?
Thank you. Yes, thank you, Madam Chair. This is for Mr. Jacoby. I know he's gone over this a lot, but I just want to narrow everything down. When someone dies, who picks up the body? Who chooses the coroner or the funeral home? How do they make that distinction? And then if it's an out-of-state donation and the body is returned, who receives that body? The funeral home or the coroner? And another question, can you say no to these permits? So you're not in that chain and possibly responsible. Thank you, Madam Chair.
Mr. Jacoby.
Well, Senator, you're right. You and I have had some discussions and some time together over the past couple of years, and I appreciate the question very much. In regards to a death that becomes a coroner's matter, then that automatically is a matter that is the coroner's immediately notified, and that's an situation where it's an accident. There could be obviously an act of violence, a death at home, which is unattended, like a non-hospice death, where a person is, dying at home, and you have constant care and the doctor's attention. So the coroner would then be involved, and they will physically come and take possession of the remains. In regards to an attended death, or one that does not require the coroner, it is the family that makes the determination as to which funeral home is called in regards to care for their loved one. And that could be an out-of-state funeral home. It is then a typical procedure to where that funeral home will get a hold, unless the family has a preference, get a hold of a local funeral home. If the death occurs in Cheyenne and they're going to be buried in Arkansas, they'll get a hold of a local funeral home, either Wiederspawn or Schrader's. And we will then assist that funeral home / family with preparing the remains and then assisting with transportation or cremation or whatever the disposition is. However, in the instance of when donation is requested, then is it the funeral home that's necessarily being requested by the family or selected, or is it Donor Alliance that's notifying us directly? A lot of the times I'll get a call from Donor Alliance saying that we have an individual at the hospital. Can you help us with a permit? And so our preference, again, the family should select the funeral home. We should take possession of the remains. We should issue the temporary permit under proposed language. Donor Alliance should come, take possession, transport, do the will and the request of the family to care for that individual for donation, and then return back to Cheyenne. And then at that point, we will work with whomever the family would choose. Your question, Senator, in regards to can I say I'm not going to issue a permit? I was told very clearly that it is, as a deputy registrar, it is my obligation to issue that. It is basically it's a service that I provide basically at the request of Vital Records, the request of the department, and that it can be revoked. I'll just leave it at that. And I cannot properly operate my operation to the satisfaction of the families that we serve without being a deputy registrar. Incredibly important for the convenience, not only for the funeral home, but to expedite the services. I would say that statement made by Vital Records is unnecessary. And the reason why is because we're trying to help Donor Alliance. We're the ones getting up at 2 a.m. to get these permits, to take somebody into our care, to place them in refrigeration. That's the first question I get asked. When was the decedent placed in refrigeration? We know it's important, but it's refrigeration that's being provided by us. And we're helping Donor Alliance in that sense to do that. We're the ones getting up at 2 a.m. to issue that permit. We just ask that there's a chain of custody, that they be returned to us, and then we will help whomever, whatever funeral home that family chooses, or cremation service or whatever. It doesn't matter at that point. What do we prefer? Be Schrader's, of course. We would prefer that, but that's not the point. That's not the point. I just want to be transparent. We would prefer to serve that family, of course, but it happens all the time that we don't. We help other funeral homes throughout the state. We help people along the Front Range. We help people in Scotts Bluff and Gary, Montana, Utah. So your point is very, very good, Senator. Will they take away my ability to serve as a deputy registrar and the convenience and the help that it provides my families? They can. I would make an argument that I would probably fight that a little bit, but according to Vital Records, they do have that ability. That's why that other person acting as such, to me, is very, very broad. And to me, it's kind of dangerous, to be honest with you. And that's why the previous senator's question about the gatekeeper, I see it as more you have a licensed funeral service practitioner beholden to the state board that understands the rules and laws according to the industry. That's the individual that should be serving as a deputy registrar, in my opinion.
Was there a follow-up, Senator Hutchings?
Yes, Madam Chair. Mr. Jacoby, my commiserations to your family as well for the passing of your mom.
Oh, thank you, Senator.
I appreciate the answers to the questions. I think you've done a good job, and I hope we can help you out. Thank you.
Representative Flitner, did you have a question? Oh, okay, all right. I've lost track there a little. Did we have, where are we? Yeah, did we? Oh, there we go. I thought there was something else. Thank you, Donna, for keeping, I was like, what's happening there? Okay, who else do we have? Is the person's name on our list? Oh, okay. Who is it going to be?
Hello, Madam Chair. My name is Jennifer Prinz. I'm the CEO for Donor Alliance. Are you able to hear me?
We are.
Thank you so much, and my apologies for not having video capabilities for your meeting. And I'd like to thank Mr. Jacoby for his partnership and helping with the Donor Alliance cases that he's talked about when families choose to be organ, eye, and tissue donors. I don't represent Rocky Mountain Lions Eye Bank. They actually manage the cornea and eye recovery. I just wanted to be clear about that for Donor Alliance. We work with tissue donation and organ donation. And there are just a couple of points that as you consider your next steps as a committee, I'd wanted to make and follow up. One is that Donor Alliance does not have a desire, nor do I think that any outside organization should have permission to transfer, to have those transfer permits to move decedents across state lines. So I want to be clear about that. I think, Mr. Jacoby, you were under the impression that we might want to have that through that testimony, but we do not. I support what Mr. Jacoby has said in terms of the integrity of that process and being controlled by the state of Wyoming. And I just wanted to make record of that, Madam Chair. The other couple of issues that I wanted to be clear with the committee about is also on coroner cases where there might be an investigation or uncertainty of the type of death or how that death occurred. The coroners release the process for donation prior to Donor Alliance or any other tissue recovery agency being able to participate in that process. So we don't have things that happen where there's later not details or evidence that's maintained for the coroners. So we're able to work with the coroners as well as the funeral practitioners from the state to ensure the integrity of the process. And Madam Chair, the only other thing that I would ask that you may consider, and I would be happy to answer any additional questions, is the impact on the family for the requirement for the decedent's remains to come back to Wyoming. In our experience from the donation process, Donor Alliance obtains authorization from the family for the transfer of the decedent to the recovery center that is housed in Lowry, Colorado. So we obtain authorization from the families for that process. Typically, they have selected a funeral home at that point, and then the decedent's remains would be transferred back to that funeral home. The challenge is occasionally they've not selected a funeral home yet that they would like to work with. And so I do see some complications or additional costs or process steps if the family were to select a funeral home, say in Nebraska or Montana, to have the decedent come back to Wyoming before they could go to the other funeral home might cause the family additional time and or maybe just delaying their process. So I just, as long as there that could be consideration for that, I think it would be helpful. And then, and closing, I'm happy to try to answer any questions to Mr. Jacoby's testimony. I really appreciate his ongoing support for donation and transplantation. I think our organizations have worked really well together. So thank you.
Super. Any questions for Ms. Prince?
Yeah, Madam Chair.
Representative Connolly.
Yeah, thank you, Madam Chair. Ms. Prince, I appreciate your kind of support of Mr. Jacoby and the funeral practitioners, but I am curious if we do implement the proposed amended language, how many additional steps might the Donor Alliance have in terms of the procurement of a donated body, and what additional expenses do you anticipate?
Ms. Prince?
Representative and Madam Chair, thank you for the question. And the concerns or additional steps that could be complicated with the process would be, a timely process is important. Tissues would have to be recovered for corneas. That's within 4 to 6 hours of the death is preferred. But for other tissues, it's 12 to 18 hours. So a timely process would be important. And when we look at a brain dead patient, so a patient who might be on a ventilator but declared brain dead in, say, maybe at Wyoming Medical Center in Casper or in Cheyenne, there's a different process that would need to be in place in terms of the timeliness to be able to transfer that brain dead organ donor. If for some reason this process blocked that ability to transfer, there's significant increased costs and additional flights that would need to happen up to Casper with transplant teams and things like that. So I would just ask for consideration, collaboration as we further develop language, if that's the pathway for the committee, that we keep an eye on the timeliness of this process.
Follow up?
Yeah, follow up. Ms. Prince, have you seen the proposed amended language, and do you see it as the impediment that you just mentioned?
Ms. Prince?
Thank you, Madam Chair and Representative. I was able to view the language when I received notification yesterday about this hearing. So I have briefly reviewed the information. I had not had a chance to personally discuss this with Mr. Jacoby prior to this hearing. So I apologize for not having more detail. The thing, as I read this language, the thing that is concerning to me would be just the timeliness of the process. And then I had wanted to be clear with the committee that Donor Alliance does not see itself in any way as wanting to issue transfer permits. And currently the process works well, and we are able to get decedents back to Wyoming in the funeral homes, unless the family has not already selected a funeral home and they select a different process. So from the donation perspective, currently it works well.
Thank you. Did you follow up on that? So Ms. Urbicite and Mr. Jacoby, following up on that, and I'm going to ask the committee, I think, as I discussed before, but I'm making a little list of things we might need to deal with in October. We've got the tribal issue, and I'm looking at, again, committee, at page 4, paragraph A, where the last sentence of the first paragraph, such temporary burial transit permits require the body to be returned to the state. So, Mr. Jacoby, it seems that I can see that we might want some language there. I mean, your real issue, I think, is to have the custody before issuing the permits. If there has been formal resolution of what happens to the body after, it's possible that, I mean, I can see where we might not want to specify, or we might want to amend to be returned to the state for final disposition unless something else. I mean, I could see where if the body were to be I'm not quite sure what the polite phrasing is, worked over in Colorado, and then the family said, and now we want the body to be transported to Hawaii. You know, I mean, if there's a chain of custody going forward from that, we might want to work a little bit more on that language, because it seemed to me like your main issue is the front end. I don't know if I perhaps didn't understand. And then as to the timeliness, and obviously you have refrigeration, but there are situations where, I mean, I suppose if it's a short time and you need a few hours, is there a definition of assume physical custody? In other words, supposing that suppose you get a call at 10 at night and Donor Alliance says we'll be there at midnight, would it be possible for assume physical custody to mean that you are at the CRMC bedside and then transfer, see what I'm saying? Does assume physical custody necessarily mean transport of the decedent to your facility and then handing it over to Donor Alliance, or what are your thoughts on that?
I appreciate the question, Madam Chairman, and also I appreciate Ms. Prince's statements, and she's absolutely correct. We do work hand in hand, and we are here to support donation, and we're here to support the families and help. I will explain my thoughts on that custody issue in just a moment, but I just want to address just a couple of issues just to clarify, because it's just not a front end issue for me in regards to taking possession or custody of the human remains before a permit is issued for purposes of transporting to Donor Alliance. It's also the back end issue. First of all, I didn't suggest that Donor Alliance was requesting to be
a person acting as such under the statute requesting to issue a permit. I did suggest that. It was in a sense being suggested by Vital Records or the department if we refused to do it. So that did not come from Donor Alliance. I just want to make that clear. I also would state that the statement that additional cost to the family to transport back to Wyoming is not true. Just not true. Donor Alliance pays for that transportation, unless there's something going on that I'm not aware of. They transport back to Wyoming at no cost to the family. So should it really matter whether they're in Colorado or Wyoming as to when that human remains is either prepared for burial, such as embalmed by a funeral home, or cremated by a cremation service in Colorado? It can just as easily be done here because there's no additional charge to the family to have that individual transported back up because Donor Alliance is responsible. In fact, it's a cost savings to Donor Alliance to leave the individual in Colorado to then be, in a sense, removed or picked up by a local funeral home or a cremation service. So I would disagree with that. Lastly, there's a difference between an individual who is clinically dead, meaning brain dead, and there's going to be donation, in my opinion, than what I'm talking about in regards to the process for purposes of Donor Alliance. And so I don't want to get into all of that. And I will tell you that, there's some ethical issues there, and I've struggled with those as a human being and as a Christian. But regardless, we've attempted to help those individuals. Do we take custody of that individual? Of course not. Of course we're not, because they are then being, whatever is being done, whether they're being moved from outside or whatever needs to be done while that person is, quote, brain dead before the physical death occurs is another issue. So I don't want to discuss that per se, because I think it kind of muddies the water a little bit. I just want to focus on the skin, the tissue, the bone donation that was discussed earlier. As far as assuming custody, Madam Chairwoman, I think that it would be, I don't know if that makes sense from a funeral service practitioner's standpoint for me to go to the bedside to receive somebody from Donor Alliance to take possession where there's no refrigeration. I think to me, it would make more sense that we are notified to come and take possession. We transport, place in refrigeration, and then we work with Donor Alliance to take possession at that point, because that's not happening in Cheyenne. The individual is lying in bed, for instance, waiting for Donor Alliance to come. So that's just my initial thoughts on that. I'm not saying that it's not a workaround, but I just want to make perfectly clear, this is not just a front end issue. This is a back end issue. This is a back end issue of these remains being released to an unregulated industry within the state of Colorado that could possibly end up impacting a family under the circumstance similar to what has occurred in Montrose. So I'm not saying Donor Alliance is wanting that. I'm not saying they're encouraging that. I'm just saying that it can possibly happen because we've seen it happen. And so it's a two-phase issue. Now, out of transparency, there's going to be some folks going to say, well, Jeff's just trying to protect the industry within the state and have those remains returned. No, what I'm trying to do is protect the interests of the family to have that individual returned. I'll issue a final permit to whomever. Family didn't pay extra to have that human remains returned. If they want to work with Wiederspan, as an example, my competitor, to have the cremation done or have the embalming done and then have it forwarded to Arkansas, fine, whatever. John can come to the funeral home, take possession, prepare the remains, work with that other funeral home and do that. But this belief that we're delaying the process, maybe we are delaying it by an hour and a half, 2 hours, possibly. If it has to go to Casper, possibly further, but you're also protecting the interests of the family to make sure that that remains is returning to the state in which it passed. So it's a two-pronged thing. And I really want to make sure that I clarify that comment because it's really important on both sides of the issue.
So actually, and I'm going to just circle back two more questions just to make sure. So it is my understanding and my experience that to be transported across state lines, the person needs to be, in essence, I always thought, at least in the states where I know, in the hands of a funeral home. So in my Hawaii example, perhaps that wasn't very good because they would have to be in the hands of a Colorado funeral practitioner to fly them to Hawaii anyway, I guess. So whether it's you or a Coloradan, but then this, and maybe Ms. Prince might want to put in this Lowry, Colorado Recovery Center. Is that a crematorium or what?
Madam Chair, thank you for the question. No, we have it's essentially, if you could imagine, an outpatient surgery center that is set up with 3 operating rooms, a morgue cooler, actually something that looks very similar to an intensive care unit to be able to manage brain dead organ donor cases, where decedents are transferred. And if we use the Cheyenne example, we work with a Wyoming transportation company and or funeral homes to transfer decedents from Wyoming to the recovery center for the recovery to take place, and then transfer back to Wyoming. I appreciate the opportunity to clarify in terms of cost. Donor Alliance pays that transportation cost to and from the Cheyenne example, if we use that. Where I think there could be additional costs is if a family decided they wanted to use, say, a Nebraska funeral home, that Donor Alliance would pay the transportation from Colorado to Nebraska versus the family having to pay the transportation from Cheyenne to Nebraska. So that's where any additional costs might take place. But yes, if you could picture an outpatient surgery center, that would be what the Lowry Recovery Center looks like. And if any of you are ever down in that area, I would love to give you a tour. So thank you, Madam Chair.
So at the Lowry facility, after you have finished your collections, is the decedent then turned over to a Colorado funeral home for transport to Nebraska or wherever? I mean, how do, my experience has been with where you needed a funeral home to go from one state to the other. So who takes custody of the decedent after you're done with them in Lowry?
Right. So if the decedent is transferred, say, from Cheyenne to the recovery center in Colorado, the tissues are recovered, and then that decedent would be transported back to the Wyoming funeral home that the family is working with. And that's what happens
But
nearly.
who does the transporting? That's what I mean.
The either the funeral home who transferred from Wyoming to Colorado, typically they will wait during the recovery that takes place after a couple of hours and then transfer the decedent back. There's also a transportation company from Wyoming that helps out funeral homes that could also be involved in that process. So if a family if they have not selected a funeral home yet and the decedent came from Cheyenne to Colorado, and then the family decided that they wanted to use a Nebraska funeral home, either Nebraska funeral home would send their transportation to Lowry to transfer the decedent to Nebraska, or the Wyoming funeral home might be able to do that if they chose to do that transfer.
Got it.
Thank you.
Okay. Isn't this educational, dear committee? Okay. Any more questions for any of our folks online?
Yes, ma'am.
Senator Hutchings.
Thank you, Madam Chair. This is to Mr. Jacoby again. Are there other local health registrars besides you here in Cheyenne? Question number 1.
Mr. Jacoby.
Yes, the health department would be that individual. Would be the department that would provide that. But of course, as we know, they're not open at 2 in the morning when it seems like all the deaths occur sometimes, unfortunately. So.
Do you have a follow-up,
Gotcha.
Senator Hutchings?
I do have one. I kind of forgot it. I wrote it down. I'm writing down so many notes because I do find this interesting as well. But I've lost my little note on that. But when I do get it back, I will want to ask a question.
Or we might let you wait until October if we proceed.
Okay. and that might be fine too. But yeah, I just want to know if he was the only one in Cheyenne. And then here's one, Mr. Jacoby, Madam Chair. It seems like when we have these issues that deal with the funeral homes, you are out front and laboring to get a lot of laws passed for the funeral homes. The other one in town, we don't hear a lot from, can you, if you don't mind, if you'd rather wait and do it some other time, we could do that too. But why are you so involved in all this and not the other funeral home?
Mr. Jacoby.
Well, out of respect for John Radomski, we have a polite, competitive existence here in Cheyenne, and I have a great deal of respect for John. I think Cheyenne is very blessed. It has 2 excellent funeral homes. We like to think we're maybe just a step better, but I'm sure John would disagree with that. Maybe because I'm more vocal, maybe because I'm nearing the twilight of my profession, maybe. Maybe I just feel called to be more out front about this. But not only that, I've seen what this statute has done actually in action. I've seen how there's been confusion and where are the remains? Where are they going? I've just issued a permit. I have no idea who this discount cremation service is. The statement that additional cost to the family, I'll just educate you briefly, and then I'm going to just make a final statement in regards to the process and how we're going to be as helpful as possible. And that is that when a death occurs and the individual goes to Donor Alliance and there's another funeral home selected, let's say in Idaho, for instance, I can tell you traditionally, typically, the procedure is that the funeral home in Idaho is going to get a hold of a local funeral home in Colorado to assist them with whatever the request is from the family. For instance, if they're going to be buried in Idaho, they're going to get a hold of a funeral home in Colorado, take possession from Donor Alliance, and they're going to do the embalming. It's the same exact procedure that would take place if the individual is returned to the state of Wyoming. So I'm sorry, out of all due respect to Ms. Prince, I am not in agreement with that statement, because most of the time, if they're going out of state, they're going to be using a local funeral home in Colorado in that instance to help with the initial preparation, and often transportation to the airport, and then of course forwarding to Idaho as an example. Lastly, unless there's more questions for me, I just want the committee to know, yes, I'm sorry.
Senator Hutchings.
Madam Chair, I wanted him to finish, but yeah, I do have one more follow-up, but go ahead and finish, Mr. Jacoby.
No, I'm sorry, Senator. I hope I didn't cut you off. I
no.
just wanted the Senator and Madam Chairman and the rest of the committee, I just want you folks to know that we are in full support of working with LSO, full support in working with Ms. Prince and Donor Alliance to resolve this issue. The goal is to protect the interests of the family and to protect their loved one. And I'm not saying that Donor Alliance has anything to do with that. I just want to make sure that they're returned, there's chain of custody, and then we work directly with whomever the family should choose, and not being released to an entity in Colorado in an unregulated state.
Okay, Senator Hutchings, last question.
Thank you. I remembered my question, and it goes back a little ways, Mr. Jacoby, where you mentioned that a body could leave, let's say, a facility, go down to Colorado, Donor Alliance can do their thing with the body, and you get it back, and maybe you notice bruises around the ankles, and all they needed was the eyes or something. What I'm wondering is, if a body leaves a facility, instead of going straight to Colorado Donor Alliance, you get it, you examine it, then you send it off. What expertise do you have when it comes to examining a body? Like you said, it may have been in a facility, but you found out maybe there was something hanky-panky going on, and it looked like it was an attended death when it may not have really been an attended death. So what's your expertise in examining that body?
Mr. Jacoby.
That's a wonderful question, Senator, because I am not certified like the county coroner in another state, like a medical examiner, to make that determination. But I will tell you that there have been a few instances in my approximately 30-year career that we have noticed that there are some concerns, and we will pass that on, even though it is an attended death, even though we've already been working with Donor Alliance, or maybe not even working with Donor Alliance. Maybe we've taken possession, and there's some suspicious bruising, maybe a handprint or something like that, right? And so we will get a hold of our coroner, and we will have them come and take a look and question that. We, in a sense, turn that over to the coroner. They will do a visual examination, and then we will go from there. On the backside, we take possession of the remains back from Donor Alliance if there's an issue. Of course, professionally, ethically, I feel obligated to share that with the coroner as well. Does that happen often? No, but I think it's a very good point. You're talking about chain of custody. You're talking about a human remains leaving the state. You're talking about disposition of cremation where there is no going backwards. That's why I think it's important. Another reason why I think it's important, but ultimately, we will work with LSO. We will be more than happy working with Donor Alliance to do right by that organization because they're doing good. And we just want to make sure that these families are taken care of and protected.
Very good. Okay, hearing no further questions, Senator Baldwin?
Thank you, Madam Chairman. I would move that the committee ask LSO, ask politely, I might add, to draft a bill for us following that. I believe it's page 4 is what we decided, the proposed amended language, following that language. And we use that language as our vehicle or our framework for our October meeting, knowing that the funeral practitioners are going to meet with the tribes and any other thing that we've asked them to do. We use this vehicle and take that input and formulate a final bill with amendments as we need. But I would propose that we have that bill drafted by LSO.
Do I hear a
I
second?
second that.
Okay, seconded by Furfeet. Is there any opposition?
No.
Okay, LSO, you good with that? All right, so you've got the language there on page 4. We'll go forward. Okay, thank you, Ms. Erbekite. All right. That being, we've reached the end of the morning. We're an hour and a quarter behind, roughly. And we'll hear from the coroners after lunch. So it being 12:50, I would say we'll be back at 2 o'clock. And folks, let's try to talk fast this afternoon so that we are not late for our tour of the coroner facility. So the meeting is in recess until 2 o'clock.